Yeah, sir. Visible, sir. Just
Yes.
put it on play mode.
Yeah.
Yeah.
So I am Dr. Manish Dhawan. I am the webinar moderator, and I'll be the host for this thing. Then coming to the whole team, the IO team, we have Professor R.C. Meena, and he is our IO president. I'll go slightly fast because to save time. And Dr. Shiv Shankar is our president elect. Dr. Ramesh Sen, he is vice president of IOA. Dr. Atul Srivastava, he is present with us. He is the honorary secretary IOA. Dr. Professor Lalit Mani, he is editor of Indian Journal of Orthopaedics. And Dr. Sandeep Kumar, he is the joint secretary of IOA. Dr. Sanjay Dhawan, he is joint secretary of IOA. Dr. Raj Gopalan is our PG teaching committee chairman. Dr. Harsha Shah is also PG training committee member. Dr. Ray and Dr. Rajesh Goyal. So this is team IOA. And Dr. Ravi Chauhan, he is webinar coordinator who is, working behind the scenes. Dr. Ashok Sham, everyone knows he's from OrthoTV, and because of his contribution, we are live today. Dr. Neeraj Bijlani, he is his associate, and Dr. Shamshul Hoda. Now, this webinar has 5 important faculty, and one is Dr. Shankaracharya, Dr. Ram Chadda, Dr. Vijay Raghavan, Dr. Mallikarjun Swamy, and Dr. Saurabh Kapoor. And we have esteemed guest panel of state of Jammu and Kashmir and Uttarakhand, and Dr. Nasir Mir from Srinagar, Dr. Rajesh Gupta from Jammu, Dr. Tribhuvan Agarwal from Uttarakhand, Kashipur, and Dr. Himanshu Kochar from Dehradun. Now, Dr. Shankaracharya, he is professor of orthopedics at Gripmar, and he is senior consultant and chairman of Department of Spine Surgery at Sir Gangaram Hospital. He has numerous national and international publications to his credit, and he has delivered many guest lectures. And he is president-elect ASSI and the president Spine Society of Delhi chapter and former chairperson of AO India Spine. Welcome, Dr. Shankaracharya.
Thank you.
Dr. Ram Chadda, he is consultant spine surgeon at Jaslok Hospital, Global Hospital, and Leelavati Hospital, Mumbai. And he has more than 30 years of experience of spine surgery. He is former professor and head of department of orthopedics at KJ Somaiya Medical College and Sion Hospital, Mumbai. He is pioneer in minimal invasive cosmetic spine surgery in India. And he is former president of ASSI and Bombay Spine Society, Bombay Orthopedic Society. He is former chairman of Foreign Fellowship Committee of Indian Orthopedic Association and recently pioneered robotic spine surgery. Welcome, Professor Chadda.
Thank you so much, sir.
Dr. Vijay Raghavan is Vice Chancellor at Sri Ramchandra Institute of Higher Education and Research, Chennai, Tamil Nadu. He has more than 30 years of experience of practicing orthopedic surgeons. And he's a practicing for more than 30 years and former president of Tamil Nadu Orthopedic Association, former president of Association of South Indian States, member of various expert and academic bodies, has more than 72 publications to his credit and delivered 4 orations and numerous lectures. Welcome, Dr. Vijay Raghavan. Dr. Mallikarjun Swamy, he is professor of orthopedics and head of the spine unit at St. John's Medical College Hospital, Bangalore. He is at present president of Karnataka Orthopedic Association. Welcome, Dr. Mallikarjun. Dr. Saurabh Kapoor is a young, dynamic spine surgeon working in Delhi. He is trained in scoliosis surgery from UK. Welcome, Dr. Saurabh. Now, our guest panel includes Professor Nasir Ahmed Mir from Jammu and Kashmir. He is professor and head of Kashmir Institute of Medical Sciences, and he is past president of North Zone and a fellow arthritis and joint replacement surgery at Ranabat Orthopedic Research Foundation. He did his training from there. Dr. Rajesh Gupta is professor and head of orthopedics at ASCOMS and Hospital Jammu, secretary of Jammu and Kashmir Orthopedic Association. He is member of Rural and Social Orthopedics IOA. Welcome, Dr. Rajesh. Dr. Tribhuvan Agarwal is president of Uttarakhand Orthopedic Association. He has presented many papers at various conferences and has many publications to his credit and organized NailsCon in 2017 and UKCon. Welcome, Dr. Tribhuvan. And Dr. Himanshu Kochar is Secretary of Uttarakhand Orthopaedic Association. He is consultant at Max Super Speciality Hospital, Dehradun. Has more than 16 years of experience in field of sports injury and knee replacement. Has several publications to his credit and delivered numerous lectures at various conferences. Contributed to chapter in a book, The Knee Comprehensive Review. Welcome, Dr. Himanshu. Dr. Ravi. Dr. Ravi, can you hear me? Yeah. So now our first speaker is Dr. Mallikarjun. Dr. Mallikarjun.
Yeah.
He'll be speaking on us on lumbar canal stenosis. So I request all the faculty and panelists to keep themselves mute so that Dr. Mallikarjun can do his first presentation. Dr. Mallikarjun.
Yeah, let's start. This one, clicker.
Sir, if you are sharing a slide, can I request Dr. Atul Srivastava for a minute to Dr. Atul?
Yeah. I think you can see.
Yeah, yes. You can see. Dr. Atul, can you do the opening remarks, please?
Oh, welcome, friends. Good evening, and this is a unique IOA PGE platform that we are organizing. This is the 5th module that we are into and we have planned around 20 modules covering almost every aspect of orthopedics. We have a fantastic faculty, and I also thank the Jammu Kashmir Orthopaedic Association, Dr. Nasir Mir and Dr. Rajesh Gupta, and Uttarakhand Orthopaedic Association, Dr. Tribhuvan Agarwal and Dr. Himanshu Kochar, for being an active part of this module. Welcome and enjoy this learning. Thank you.
Dr. Mallikarjun.
Yeah.
Please start your presentation.
Yeah, good evening to all. First of all, I'm thankful to Indian Orthopaedic Association President Dr. Meena and the Secretary Dr. Atul and Dr. Manish and IOA Teaching Program Chairman Professor Rajgopalan and other co-members of the society. I'm honored to speak on this. Of course, I'm doing the spine work together with Professor Rajgopalan last 25 years. In St. John's, and this module I have taken only for the basic for the students. I'm going to speak on this outline. First, definition and diagnostic criteria and history and etiology, anatomy and pathophysiology and clinical features and differential diagnosis, management and a little bit of review literature. And what is the definition of lumbar canal stenosis? Lumbar spinal stenosis is defined as circumflexed osteoligamentous narrowing of the spinal canal. It usually occurs in cervical and lumbar spine. About 5 of every 1,000 Americans more than 50 years is going to suffer in this condition. About 1 in 1,000 more than 65 years usually undergo one or the other procedure in the form of surgical intervention in European countries. And diagnostic criteria for defined lumbar canal stenosis is vary in the different literatures, but intraspinal circumferential measurement, if it is less than 76 millimeters square, we call it as severe. Less than 100 millimeters, we call it as moderate. But AP diameter is less than 10 millimeter, you can call it as in generally as a lumbar canal stenosis. But one should remember in this point, for the students especially, there is no clinical correlation between the severity of the symptom and radiological findings. Go back to the history of this lumbar canal stenosis. First, better to remember Hank Orbiest. He is the first person to describe the spinal stenosis, authenticated, and one of the classic symptoms of spinal stenosis is intermittent claudication of the spine. Is called as, named after him, called as Orbiest syndrome. Coming to the etiology is a part of the aging process, and it is not possible to predict who will be the affected first. We don't know who is going to the candidate is going to get. There is no correlation between the occupation, race, body type, and sex. There are 2 types. It could be in a younger age group and secondarily in the elderly age group. And coming to the little bit of anatomy of the spine, we all know that when the person stands walking, there will be extension and impingement of the nerve root can happen. When the patient or the individual sitting on bending forward, there is a compression on the neural structures will reduce That's the basic thing. Coming to the pathophysiology, there will be facetal arthropathy and osteophytic growths, hypertrophy of ligamentum flavum, and herniated nucleus pulposus, and disc spurring can happen. Sometimes it may add on to the problem with degenerative spondylolisthesis. Underlying effect is not only the mechanical, but there will be a decrease in the CSF flow, and local ischemia is the most important than the mechanical compression. That is the one is going to give the more symptoms to the patient. We know that in a lumbar healthy vertebra, it provides the body support. Disc acts as a shock absorber, and vertebral protects spinal cord and nerves. Nerve have space and not impinged in normally. In a case of stenotic and degenerative spine, as the age progresses, ligamentous and bony structures can become thickened, and eventually it will cause narrowing of the spinal canal. And narrowing squeezes the several nerves in the spinal canal and nerve roots exiting spine, and it may cause the radiculopathy in the legs. The results, it may cause the pain and numbness in the back and legs. One should remember that the lumbar canal stenosis, more of the history taking, and usually in the examinations you won't get much. Coming a little bit of the zone of stenosis where it can, the neural structures can be impinged, it can be central, or it can be lateral recess, or in the pedicle level. In the pedicle level, you can see in this stage, and the intermediate zone are in the disc. Coming to the central stenosis, what are the structures can cause central stenosis? It could be a ligamentum flavum buckling, ligamentum flavum hypertrophy, disc protrusion, or degenerative disc pathology, or hypertrophic zygoepiphyseal joints. Degenerative spondylolisthesis itself can cause the central stenosis. Coming to the lateral stenosis, it can happen in the entrance zone, or it could be in the mid zone, or in the exit zone. In any of these three zones, it can happen. Coming to the lateral stenosis due to a synovial cyst can also happen. Simple degenerative cyst can present, and compressing on the nerve root can cause the canal stenosis. In the entrance zone stenosis, usually cause could be the hypertrophic osteoarthritis of the Z joints, posterior disc herniation. In the mid-zone stenosis, causes usually defect of pars interarticularis. It may causes the spur under the pars and attachment of the ligamentum flavum. Pedicular kinking can happen, lateral disc protrusion can happen, and again spondylolisthesis can cause the mid-zone stenosis. Exit zone stenosis usually because of the hypertrophic osteoarthritic changes in the Z joint. All this can cause the canal stenosis. What are some theories I put forward? It could be a venous engorgement or arterial insufficiency theory. But really we don't know about the arterial insufficiency, but definitely about the venous engorgement theory. There will be increased epidural and intrathecal pressure. Microcirculatory neuroischemia can cause, but to cause this kind of stenosis, it could have at least two levels of stenosis, either central or lateral, to increase the pressure. Coming to the symptoms of the lumbar spinal stenosis, mainly the elevator syndrome, what we call, as I already shown in the previous slides. When the patient start standing and start walking, it provokes the symptoms, pain and weakness in the legs, and patients suddenly try to lean forward and take support of the, like wheel cot like this, and they will get relief on the sitting on the chair and bending forwards. This is called as elevator syndrome. And symptoms of lumbar stenosis, it could be classical presentation like dull or aching back pain spreading to legs, a numbness, pins and needles in legs, cough and buttock, weakness or a loss of balance can happen. A decreased endurance for the physical activity is the most important. As I already told, it's a disease, you should diagnose the symptoms. Examination wise, most of the time you won't get much. And range of movement of all the hip joint, the sacroiliac joint, and DTRs usually will be normal. And usually, unless you do the examination of the EHL and EDL or peroneal, it will make what you call as claudication test. It will make you to make the patient to walk for certain distance. When you get the pain, if you examine, you may get weakness grade 1 level low, otherwise you may not. Sensory may be variable, and vascular examination is a must for all these conditions, because even vascular can mimic like this. One should, before diagnosing the lumbar canal stenosis, vascular insufficiency should be ruled out in all the cases. But coming to the differential diagnosis, we have differential diagnosis can mimic very closure. Piriformis syndrome, where the sciatic nerve can compress in the rotators, and trochanteric bursitis, and early OA of the hip joint. And as I already mentioned, vascular claudication should be ruled out, and sacroiliac joint pathology. A non-specific back pain from the spondylolysis itself, one should rule out, and distal polyneuropathy when the patient is having the other conditions like diabetes mellitus and spinal cord vascular malformations. And inflammatory conditions should be ruled out, and especially the patient seronegative arthritis, and it could be sometimes the post-viral infections, and very rarely you have to try to look into any malignant problems in the spine. Coming to the investigations, of course, thorough clinical examination is the mainstay in clinical diagnosis of the lumbar canal stenosis, and you need to take customary to that, routinely you have to take the X-rays, both the stress use, flexion and extension use, and the CT scan is a must, and MRI is the gold standard in all the cases, and myelo studies is required in certain situations. And coming to the treatment of lumbar canal stenosis options, of course, you can group into 3 categories. It could be mild, it could be moderate, and severe, and depends upon the patient, the suffering, and depends upon the neurology and deficit. But in early cases, the patient endurance is good, occasional pain, you can always opt for non-operative care, like a little bit of lifestyle modifications. You can go for a pharmacopoeia in the form of NSAIDs and other drugs, exercise and weight reduction, and chiropractitioners, manipulations, and sometimes you can use the epidural injections. In the moderate cases, either it may not require any major surgical interventions. We can go on putting the spacers, interlaminar spacers can be used that can prevent the impingement on the neural structures. But lastly, in the severe cases where patient endurance and day-to-day activities come into a halt, it will affect the day-to-day lifestyle. You need to go for surgical intervention measure, where you can go for in the form of decompressions and with or without instrumentation. Depends upon the how many levels, whether it's associated with any instability of the spine or not. Medical management, it could be a pharmacopoeia. Variable drugs can be used, including with the methylcobalamin, calcitonin, prostaglandin, gabapentin, muscle relaxants, opioids, and steroids in the form of epidural and local. And the physiotherapy could be in form of tractions, electrical stimulation, stents, manipulations, and braces. And surgical management, moderate to severe symptoms, urgent surgical decompressions may be required. Sometimes patient will move on within so many years with the radiculopathy. Suddenly they may land up with the myelopathy signs clinically, and they may come with the cauda equina. And such situation, you need to go for immediate surgical decompressions, and where the patient will have severe radiculopathy where quality of life is compromised. Surgical options, lumbar canal stenosis, it could be a decompression with fusion, decompression with instrumentation and fusion, interlaminar spacers. And stabilization in the stable spinal stenosis is a controversial actually in the literature wise. Some report they use the ipsilateral nerve root decompression and fusion. Others have reported their preference of contralateral autologous bone fusion to preserve the segmental stability. And the posterolateral intertransverse fusion bilaterally through a midline approach, local autograft and allograft. Interbody space best in terms of biomechanically. Interbody fusion with transpedicular fixation more stable. Need fusion for controversial and especially in an instability. Okay. Anterior lumbar interbody fusion indirect root decompression used for severe back pain with limited disc bulging. And dynamic stabilization and mobile devices is more popular some years back. Right now, the usage has come down now. So this is popular because of protect adjacent segment from more rapid degenerations. Dynamic devices stiffen the spinal motion segment but do not eliminate the motion completely. It allows some movement in adjacent segments and above and below and the inclusion segment also. Minimally invasive techniques and decrease trauma and indirectly decompose the neural elements, technically demanding, high cost involved, and internal laminar spaces one can use. We can elevate and put a spaces, and the kissing spinous process can be put into back to the space to prevent the impingement of the nerve roots. These are some cases. Here the patient is 60 years old male with 2 years of back pain. He suddenly landed with discomfort in the urine and cauda equina, clinically diagnosed. He has come with a severe massive disc, chronic degenerative disc on table, decompressed in several levels. This single sequestrated disc was removed, adjacent canal decompression was done and fixation was done. This is another case, a 60-year male with 1.5 years of claudications. And this is the post of decompressions and follow this another case with an retropulsion of a TL45 instability with lumbar canal stenosis, decompression and standard pedicular fixation, and we have given the good sagittal balance in this case. And again, one more case with a claudication of 2 years and multiple level compressions, standard decompression and stabilization was done. This is another case with a claudication of 1.5 years, decompression and follow of almost 6 to 7 years. Another case with a claudication instability, 64-year male. And this is the one with an decompression and stabilizations. This is again another case with a cauda equina with minimal degenerative instability. Again, fixation and stabilization was done. This is another case with multiple levels and good decompression and with a multiple pedicular screw fixation, got back the sagittal balance. This is another case with a similar scenario. This is another case with a similar scenario. Coming to the few literatures, of course, central lumbar spinal stenosis, natural history is a non-surgical patients. Findings and diagnostic imaging do not influence the clinical and outcome. One should assess each case individually. This is another literature where surgical treatment of lumbar spinal stenosis with micro decompression and interspinous distraction, device in insertion, a case series, they are given a good report about that. Suppose Journal of Spine Surgery, again, fusion of surgery for lumbar canal stenosis. Simple decompressive laminectomy or lumbar spinal stenosis should remain the mainstay of clinical practice, with fusion reserved only for the case of proven spinal instability. Take-home message, lumbar stenosis should be differentiated from vascular and peripheral neuropathies. Surgical treatment is warranted in severe symptoms with progressive neurology. With presence of instability, fusion is indicated. Central and root canal wide decompression and evacuating the sequestrated disc gives prompt result for the patients. Choice of procedure and the decision of fusion is individualized for each cases. Thank you. Thank you for giving the opportunity.
Thank you, Dr. Mallikarjun. Thank you for such a nice.
He has to leave. Can we ask some questions?
Yeah, can I request Dr. Nasir Mir for his comments or question for Dr. Mallikarjun?
For the benefit of the students who are watching, I would like to know how would one person differentiate a vascular claudication from a neurogenic claudication?
So one is starting with the age group and then is clinical thorough classical examinations. One should also mention in my slides, you have to thoroughly check the distal vascular status. Distal pulses is a part of your examination protocol. When you have a distal pulses are weak or any doubtful, you have to first rule out, do the necessary Doppler test. That's more important. Of course, history-wise also we have several symptoms. Is a you can always differentiate between the neurological and vascular claudications. We all know that the neurological claudication is better within a uphill, and it is worse with the vascular claudication, and distance is variable in the vascular claudications, and neurological claudication is not so. Like that, you can differentiate in the history also. But a clinical examination, any doubtful, one should go for the Doppler study of the arterial study that you can differentiate.
Second thing is, how can one differentiate a radicular pain of lumbar canal stenosis from a peripheral neuropathy?
Peripheral neuropathy usually start within the pins and needles from the peripheral slides. Usually start in the stock and glove type of that. Most of the patients will have the diabetes mellitus and other associated things. But in canal stenosis, usually start with L4-5, classically start with back pain, and typically after some claudication time, it traverses below the knee and goes down. That is the important thing you have to notice.
One more point is, what about the hip? Sometimes hip pathologies are being missed in the lumbar canal stenosis, and patient has a pathology in the hip. Do you advise something to the students regarding this?
Always doing the spinal examination, you have to examine the hip examinations, and the sacroiliac joint examination is a must. After the rollout of the SLRT, you have to do the passive SLRT, you have to look for the movement of the spine, internal rotation and external rotation. When there's a complete range of the internal and external rotation is full, almost you are clear to 100% that hip pathology is ruled out. But at the same time, you have to rule out the sacroiliac test and to rule out the sacroiliac pathology also.
What is the recent thing, what is being discussed, that over-the-top decompression in spinal stenosis? What is that? Over-the-top decompression in spinal stenosis. Over-the-top decompression. And they do, with microscope, they do decompression for one side, and then they don't make the spine unstable.
Yeah, that's what in previous slide I have mentioned. In the microfiche surgery, they can go for endoscopic system, they can increase the canal from the other side, and they can remove the spinal disc herniations. They can increase the canal, decompression can be done. Those who are well studied with endoscopic procedure, that can be performed.
Correct.
I think Ram will answer for that more, because I do more open surgery in my practice.
Dr. Ram Chadda, your comments, please.
So over-the-top decompression is done when you're doing something like a tube decompression from one side, where you put in the tube and you've then gone sub-spinous, below the spinous process without doing a laminectomy, and you've undercut, removed the ligamentum flavum so that you can see the other side root as well. So in that, what you do is that you put the tube from the more affected side, you do a complete decompression of the exiting and the traversing root on your side, and then undercut or go below the lamina, remove the soft tissue, and keeping the dural elements down, you go over the top of the dural elements onto the opposite side. That's the over-the-top decompression.
Dr. Tribhuvan Agarwal. Dr. Tribhuvan, can you hear us?
Yes, sir. Yes, sir.
Your comments or question for Dr. Mallikarjun?
Sir, I have a good experience for epidural injection, caudal epidural in the lumbar canal stenosis. What is your comment, sir?
Sir, caudal epidural can be advocated for the early symptomatics and the mild symptomatic patients, and those who are not fit to go further or not willing to go for the surgery. Now, two of my patients, they will come every 4 months and 5 months for epidural, where they are not willing for the surgery. That can give the relief, or at least for a few months in our practice. Actually, that's one of the method of treatment one can use it.
Dr. Himanshu Kochar, please. Dr. Himanshu.
Sir, good evening. Nice presentation. I want to ask, in the management, you have mentioned the role of gabapentinoids. Is there any role in lumbar canal stenosis? And secondly, in the physiotherapy section, a traction was mentioned. How oft is traction in nowadays? Whether you give tractions and how they are helpful in managing these patients?
See, sir, coming to the first question, is happening gabapentin pregabalin. In some patients, it may work. But we know that ultimately you have to decompress the canal, isn't it? These are all symptomatic treatment. Early stages, it may work for some patients, it may not work. Coming to the physiotherapy part, these are the things given in the book standard textbooks for the benefit of the student. I have mentioned that may not give the tractions anything on this. Some patient may get benefit, may not get benefit. For the completion sake, I mentioned.
Okay, sir. One more comment on gabapentinoids. One should, before giving them for the long term, one should always rule out a glaucoma in those patients, because it has been seen that these drugs can worsen the glaucoma part. So it's an important thing to remember that, because it may be damaging to the eyes, and we don't even ever peep on that side also. So for the PGs and for the other people also, like if patient have some glaucoma issues or some issues with the eyes, so like a prolonged treatment with the gabapentinoid should not be done.
Yes, yes, that's agreed. Most of the patients we send any doubtful about that, optal opinion should be taken in those cases. You agree?
Yeah,
with that?
just a point. Yeah. Thank you, sir.
Dr. Rajesh Gupta, are you with us? Okay, over to Dr. Raj Gopalan for his comments. Dr. Raj Gopalan.
Muted.
Dr. Raj Gopalan. Sir, we can't hear you, sir. We can't hear.
Yeah. Thank you, Dr. Mallikarjun. It was a very nice talk. Covered completely the all what the student needs from the exam point of view, lumbar canal stenosis, giving overview of all the various managements, and it was very nice. Thank you.
Thank you, sir. I thank to Ram and Shankar to allow me to present. Before
one query. Actually, I have one more query. There you have fused a lot of segments. Actually, this question is for Dr. Ram. You have fused a lot of segments. What is the limit? How you should go up? Because I have seen one of the slides in previous year in Dr. Ram Chadha showing that he was going up, and fusing the whole spine. So what is the limit? Is it necessary to fuse? Because you don't know additional segment degeneration. How far you are going on?
Sir, I have a very simple answer. What I shared with you and what you've seen, where I started at lumbosacral junction and I ended up after 6 surgeries at the cervicothoracic junction, are the lessons I've learned from those challenges. Today, what I've learned is that fusion has to be restricted to a mobile, painful segment alone. If I don't find mobility and pain related to the mobility, I do not fuse.
Correct.
Okay.
Thank you.
Any other comment from the faculty, or we go to Dr. Ramchadda's presentation on tuberculosis spine? Any comments from the faculty? Dr. Ramchadda, I think you can start with your presentation. I have not received questions from the audience. Once I receive, I will ask them. Dr. Ramchadda, please. Dr. Mallikarjun, you can go. You have to go to a webinar, and your questions will be taken by Dr. Raj Gopal.
Yeah. Thank you.
Good evening, everybody. I'm going to be sharing with you the students like me who are learning each day from each patient something more about tuberculosis of the spine. This is an ailment that has been with us for times immemorial, and every time that we think about it, we learn something new. I may be just giving you reminders, but please understand that these reminders will go a long way in helping us take the way forward. May I share with you that tuberculosis is probably the biggest masquerader in the spine. There are so many diseases that look like tuberculosis, and you think it is tuberculosis, and there are times when you're very sure that it is some other disease and it turns out to be tuberculosis. So I am here sharing what I have learned over the years. Unlike everything else in orthopedics, where there is purely a biological and mechanical component, in spine, besides biology and mechanics, which can affect the disc and the bone, there is a huge neurological component which makes things even more difficult. I share with you the little that I know based on evidence, which you have more access to because all of you read much more than I do today. But I would combine the evidence with experience and share what we call expertise-based knowledge. We have 3 basic presentations which will come to us in the examination as long cases. These could be a complete paraplegia, incomplete paraparesis with myelopathy, or a thoracolumbar deformity. You may have a patient who's totally shut down with trophic changes, unable to move the lower limbs, a patient who is in pain but struggling to move the lower limbs to a certain extent, and a third ambulatory patient, young or middle-aged, who has a deformity. All 3 of them may have a diagnosis of tuberculosis of the spine or maybe something else altogether. We have to look for pain. When did this patient start having pain? Is it a disabling axial pain along the axial skeleton? Does it have any radicular intercostal radiation? And does the patient have night cries? Is he or she losing weight, getting tired, loss of appetite, evening rise of temperature? Are they losing their balance, control over urine or motion? Are they having a catheter or a diaper on? Have they been exposed to tuberculosis in the past? Many of them may not know it was TB. They'll say they had a lymph node biopsy, or they had a pleural effusion, or they were given some medicines for 6 to 9 months. Ask them whether they had discoloration of urine, sweat, sputum, even their soft lenses. Ask them if they were given medicines which were changed according to body weight. Did they stop the medicine on their own? Do they have any malignancy, liver or kidney ailment? Do they incidentally also have any old injury with a deformity of the spine or have some morning stiffness or body rashes? Have they ever had a biopsy? Have they had any operation? And if she is a lady, is there any menstrual history that she needs to share with us? Please remember at this point that you may be asked, what are the other causes of reddish brown or orange urine? And it's rifampicin, pyridium, and senna. Moving on to the examination. You may have an ambulatory patient with tolerable pain, or you may have a non-ambulatory patient with intolerable disabling pain. It may be a challenge to check his gait, movements of the spine, or doing any gravity-assisted tests. Whenever you address a patient in the exam or otherwise in practice, explain, counsel, and seek consent for each test done. These are important soft skills. A special permission for skin marking, or if you're eliciting a painful test, needs to be taken every time. Inspect the patient in standing, sitting, and lying down, depending on what is possible. From the front, from the back, and the side. Check whether the head is in the center, whether there is any visible spasm, whether there is any tilt of the pelvis, shoulders are equal, nipples are fine, arm torso distance is same, skin folds are symmetrical. Is there any costal crowding? Is there an obvious limb length discrepancy? Any swelling, scars, sinuses in the neck, intercostal region, iliolumbar region, inguinal region, even femoral region, paraspinal region at the rear, Petit's triangle, or sacroiliac joints. Look for trophic changes in the gluteal region, sacral region, trochanters, and heels. Check for a beaver sign. Why do I bring it here? Because mind you, this is the only sign which can be elicited without touching the patient and can be done in an inspection mode where the patient is made to anti-gravity, lift up his or her head, and you look at the umbilicus with neck flexion if it is being pulled up or is straying to one side. This gives you an idea that there is a lesion around D10. From the side, look at the sagittal conformity of the patient. Cervical lordosis, thoracic kyphosis, lumbar lordosis. Look for an obvious knuckle, gibbous, kyphosis, or kyphoscoliosis. Confirm from the side whether the respiration is abdominothoracic, symmetric, asymmetric, and whether intercostals are doing well. Next, move to palpation. It should be a gentle, warm, empathetic hand that touches the patient. Go from the rear and palpate. The first visible, palpable vertebra prominence is C7. However, T1 is the longest. T3 is at the spine of the scapula, T7 at the angle of the scapula, L4 is the highest point of the iliac crest, and S2 is at the PSIS or the dimple of Venus. Check for the deformity. A knuckle is an abrupt peak. A gibbous is a prominent hill, while a kyphus is a gentle hillock. The three are different. Check with the dorsum of your hand the temperature. If there's any visible swelling and the paraspinal areas. Do not miss the psoas in the front. Always look at the face of the patient for apprehension and painful wincing. Check for midline posterior tenderness, superficial, deep, twisting the spinous process. This is the one which will elicit anterior pathology, and a thrust is usually avoided if twisting is positive. Sacroiliac test should also be done and should always be done for completion. Even if you have a pathology in the spine, you may have a skipped lesion in the SI joints. Always remember, all infective and neoplastic pathologies have a painful arc in all ranges of motion. Degenerative pathologies may have one or more of the arcs spared. Check movements in the neck, thorax, sacroiliac, and lumbosacral junctions. Do the Schober and modified Schober, which is actually for ankylosing spondylitis, to check the lumbar spine mobility. Chest expansion should be checked at the xiphisternum and the mammary level. Remember, both these tests need mobility to be more than 5 centimeters for that to be normal. The Schobers as well as the chest expansion. Less than that is abnormal. If you are looking at a patient with stiffness, then also look at the tragus wall distance to rule out Angstborn, and that should be less than 10 centimeters. Keep all these things with you in your pocket. Cotton wool pins, divider, tuning fork, hot and cold test tubes, knee hammer, tape measure, goniometer, and plumb line. The neurology should be tested within the limits and ability of the patient. Rule out any higher function abnormality. Do an isometric head lift and you push it down. By doing this, you can check the rectus femoris, the upper and the lower part, when the patient is lifting the head up. Check the motors and grade it according to Medical Research Council UK, MRK, between 0/5, which is no movement, to 5/5, which is normal. Sensory should be superficial and deep with pressure. Temperature. Pinching, pinprick, and hair lift is crude. We do not do it in primary assessment most of the times. We do it only in checking recovery from a complete loss to early recovery. Check the position sense. Move the great toe up and down at the IP joint, double blind the patient and check it whether he's got sense of position. Coordination can be done by the heel shin test, rolling it from the heel of one side on the opposite shin and repeating it. This is done and you then assume that you've now got an approximate idea where we are. The neurology is now coming to the critical part. Deep tendon reflexes, upper limbs and lower limbs. If you're unable to do it and the patient is not cooperative, tell him to start counting. It may distract him and then you'll be able to elicit your reflexes. Or let him do the Jendrasic maneuver, which is holding his hands and pulling them apart. When he does that, you'll be able to elicit your tests much better. The response could be a brisk, exaggerated, normal, diminished, and use the word not elicitable. Don't use the word absent, because absent, it may be in your hands. Somebody else who's better capable may be able to do it. Superficial reflexes, check the abdominals from outside coming inside, upper and lower. Check the bulbocavernosus. Put your finger in per rectal and either pull the catheter if he has the catheter or give some Gans pressure and there will be some contraction. Anal wink, Very important. Scratch the area around the anus and there is a winking of the anus. These are normal responses. Plantar reflex, extremely important. Sharp stimulus along the outer border of the lateral heel to the forefoot. Normal is flexor. Abnormal is extensor with fanning. Having said this, there are two other things we have to look for. A sustained, ill-sustained or absent clonus in the patella or the ankle. Patella is pushing the superior pole with your middle finger, with your index finger and your thumb down towards the tibial tuberosity and keeping a sustained pressure, and you'll get this sort of a response. In the ankle, just 10 to 15 degrees flexion at the knee, and then with the palm or the fingers, give some dorsiflexion force onto the ankle, and there will be a flapping. These are all suggestive of clonus. More than 30 seconds is called sustained, less than 30 seconds is called ill-sustained, and normal people do not have clonus. Check also if there is an insidious incidental cervical myelopathy along with the thoracic myelopathy. Do a Hoffman sign. In Hoffman sign, you look at the middle finger, stabilize the DIP, distal interphalangeal joint, and passively strike it. Having done that, you will get a response of all the other digits with a flicker or a flexion. This is a positive Hoffman sign. Having said that, you will have a sensory and a motor level in your mind where the lesion is. There will be different spinal and vertebral levels, and you need to follow them. These are the important tests. That is what a brisk reflex will look like. That is what an ankle clonus will look like. And that is what a Hoffman's will look like. Any of these needs urgent attention and treatment. These are important tests, once elicited, suggestive of spinal cord compression if the lesion is in the spine. There are lesions which are supraspinal, which also have the same. Having assumed this, you are then told to classify what you think the patient has. And if you feel it is tuberculosis of the spine, you may be asked either a Kumar's classification, which is a modification of Tully's, or Jane's modification of Tully's. All of these are available and you need to classify it. Earlier, before the AKT came in, there was a Seddon's classification, and at that time, there was just an early onset paraplegia in extension and in flexion. No more that we follow those. How do we manage? This is where the whole problem begins. We as spine surgeons have blinders or blinkers and a very narrow vision as far as managing of the TB spine is concerned. Questions that need to be answered. Is the writing on the wall? Can we treat TB of the spine as an isolated entity just as orthopedic spine surgeons? Or do we need to be more proactive, more aggressive, more attentive? What do? We do standard X-rays, AP and lateral of the entire spine. We ask for MRI of the whole spine with SI joints on a 3 Tesla with or without contrast. We sometimes ask for a CT or even a PET scan. And why do we do all this? Because after having got a clinical picture, we want to correlate it radiologically and decide what is happening where. Is the lesion posterior clinically? Is the lesion anterior? Is it global? But what we need to know is that there are certain telltale signs which still can be seen on the X-ray. Like you see here a bird's nest, and here you see an early element of discitis, an early element of collapse. X-rays also have a place. Don't directly for an MRI. MRI can of course tell us about abscesses, granulomas, spondylodiscitis, osteitis, paradiscal lesions, and even atypical tuberculosis. How do we look at them? These are what abscesses look like. These are what granulomas look like. They could be paraspinal, prevertebral, or epidural. Classical lesion is a spondylodiscitis, like the one that you see. T1 weighted sag on the left, a coronal seen with a stir, and on the right side, a T2 sag, all showing us different types of the same lesion. Sometimes there is a central body lesion where the disc is sometimes spared and which may mimic malignancies. But these are all tuberculosis and these are osteitis. Rarely there may even be a vertebra plana. We may think of multiple myeloma, METS, eosinophilic granuloma, aneurysmal bone cyst, or even a giant cell tumor. But these can also be tuberculosis. Sometimes there are paradiscal and contiguous vertebral bodies with prevertebral and postvertebral sort of soft tissue shadows with the bones not much affected. Atypically, anything can be there, from a single collapse to a concertina to an ivory vertebra to just the arch getting affected to a circumferential lesion to multiple skip lesions to a contiguous lesion or skip lesions. These are all atypical posterior elements where the anterior are partly spared to begin with and may get affected later, but they all began with a posterior lesion. This is a spinal tumor where it's mainly a soft tissue affection from the rear, and it does not actually have any major compressive pathology in the front. There may be multiple vertebrae, as you see, and this actually tells us why we need a whole spine screening, because about 14 to 18% of people have skip lesions in the spine. This is where we are. Hence, where are we as spine surgeons? We need the radiologist, we need the pulmonologist, we need the microbiologist. We all believe tuberculosis is an extra pulmonary paucibacillary disease. And we all know that the treatment is anti-tuberculous chemotherapy, rest and breaks. What then is our role with chemotherapy? Frankly, I use my chest physician to advise me on this, but here I'm sharing the knowledge that I've got from him with you. There is primary and there is secondary AKT, and we have principles that we need to follow. In primary, short-term therapy, which they use mainly for pulmonary tuberculosis, they use two-month therapy with 4 drugs and 4 months with 2 drugs. This is the ultra short course. To remember, HREZ, the doses are very easy to remember. H is 5 milligram per kilogram body weight. R is 10 milligram per kilogram body weight. E is 15 milligram per kilogram body weight. S is 15 milligrams per kilogram body weight. And Z is 25 milligram per kilogram body weight. Most of the times it is HRZE that we use for 2 months. And now a lot of people have moved to just HR, which is isoniazid and rifampicin for 4 months. Yet, globally and in our country, we have not yet moved in extra-articular tuberculosis or extra-pulmonary tuberculosis to this ultra short. And we tend to still follow a 1-year dose program. There is always going to be some discussion and debate, 6 months, 9 months, 12 months, or 18 months, or till it heals, or what's the end point of healing. The commonest followed scheme in our country today is 2 months of 4-drug regime, followed by 10 months of 3-drug regime. HRZE for the first 2 months, and then RHE, daily dose, not the DOTS therapy, with close monitoring for at least 1 year. What are the secondary lines and where do you used to use them? Well, you do it when you have resistant tuberculosis, which is either MDR, multiple drug resistance, XDR, extreme drug resistance, or TDR, total drug resistance. These are situations where you have to use these drugs in addition to the primary line or the first line. They do not replace, they add to the first line. These drugs are multiple with various dose schedules, which it's best to involve a chest physician, and we should not be prescribing them directly because the side effects are far more difficult to handle. But we should know that each one of them has a combination of bactericidal and bacteriostatic, which need to be combined together and not just adding one drug to the failing regime. What do we do when we suspect MDR? Or when do we really suspect? When there's no improvement despite proper therapy for 3 months, or worsening despite therapy for 3 months, where the patient is getting an incorrect regime with inadequate doses, and we realize that things are going from bad to worse, maybe a repeat biopsy would be needed, or there is a history of irregular drug intake, or he's a known case of MDR. In all these patients, we have to repeat the AFB culture. Patients should have at least 2, if not 3 new anti-drugs added, anti-TB drugs, and you should continue the drugs for 18 to 24 months. And the final regime should have at least 4 drugs sensitive based on his sensitivity report. Having finished the medical part, I must tell you that these drugs will have to be continued for almost 2 years. They have severe adverse reactions which need to be looked at by chest physicians rather than by us. and we should involve our colleagues in this. Having said this, what is our role then? What do we do? Is there any role of surgery? And this is what I share with you today. It is a team effort, an effort that we need to do together. We must understand routine surgery cannot be recommended in such patients unless there is a well-conducted randomized double-blinded study. However, in India, we cannot do this and we have hit a panic button. So how do we decide when surgery is to be done? We follow a ritual every time before every surgery. All cases are subjected to a biopsy. The benefits of a biopsy far outweigh the possible complications associated with the procedure. This is what I recommend as a CT biopsy. I send them for HP, gram staining, Bactec plus, extended intubation, Zeal-Nielsen, TB culture, MJ, drug sensitivity, gene expert, fungal smear and fungal, and if necessary, even a linear probe assay if we need it. This is what a CT biopsy looks like. This is done by a radiologist, and the report will tell us, like in this case, rifampicin is a surrogate marker for MDR. Its resistance is not detected. MTB is there. So it's mycotuberculum. It is typical tuberculosis. This is how we read the report. Having said that, do we really need to then plan for surgery, and when do we do surgery? Well, we have to do it, and we should plan it mentally as to what type of surgery we do depending on the lesion. Is it a lesion which needs only a biopsy followed by drug therapy? That is type 1A classification, limited to one disc, no abscess, no collapse, no neurology, just some soft tissue which can be picked up or a biopsy done. Mild abscess, you can just do a decompression if it's very necessary, or just drainage of the abscess. Type 2, where there is a collapse but less than 20 degrees, with or without neurology. These patients may need a debridement and fusion with a decompression and stabilization. And a final, which is very severe, sagittal collapse of more than 20 degrees with neurology, with kyphosis, may need a global back and front job or just a back job addressing both the front and the back. What are the types of surgeries which are done? It's mainly debridement and clearance of granulation tissue and stabilization if there is an instability. Why do we do that? And is there any truth that this is facilitating the drug by reducing the tissue load? Well, there is no real evidence about it, but it's conjectural that some people believe that doing a good decompression makes the additive effect of anti-TB superior. So when do we operate? Neurological deficits caused by compression of spinal cord, spinal instability causing destruction of the vertebrae and kyphosis more than 30 degrees, no response to chemotherapy, repeated non-diagnostic biopsy, or large abscesses causing either a difficulty in deglutition or large abscesses causing collateral damage. Let's limit ourselves to thoracic and thoracolumbar spine. What do we do here? Well, we have probably the largest study coming from our own city, where Dr. Bhojraj and Jwalant many years back presented this and divided the cases into group A, B, C, and D. Most of these surgeries are from the front, and an anterior decompression needs to be done. In those days, the surgery was being done from the front for the anterior. Today, we have combined it and maybe doing it from the rear. So group A is those which are stable without any kyphosis, where you just decompress and put a strut graft. B is global lesions, which need a proper stabilization from the front, but can cause an indirect stabilization. Group C is where there is a high risk for a transthoracic surgery, where you do a transpedicular surgery from behind. And group D is isolated posterior, where there's nothing wrong with the anterior elements. Here you do purely a posterior surgery. Now, I tend to follow something which has come from across the border, which is very, very relevant. It is a study which came in from a group in Pakistan, and they had similar principles, similar approach. They spoke about augmentation of metal, and they had a full history, examination, investigation, and they gave us a score. These scores are very easy to follow. You get an A score from the clinical history, a B score from the clinical examination, and there's a localization coefficient. When the lesion is between D1 and D10, the localization coefficient is 2. D11 to L2, it's 1.5, and L3 to S1 is 1. Why is that so? Because there is a higher possibility of things worsening as you are in the upper thoracic spine, as you go towards the lumbar spine. Score is less than or equal to 5, anti-tuberculous therapy. 6 or 7, it's a wait and watch, and more than 7, antituberous therapy with surgery. This is something to tell you that there is literature today saying that in TB spine, you can use metal safely, and do not worry using anterior, posterior, or wherever you want to put metal. As far as TB spine is concerned, it is not unsafe. I share a few of our surgeries. This was many, many years back, over the last 20 years, purely an anterior surgery, decompression stabilization using rib graft within the mesh cage with an anterior Harm-Zielke type of a device, purely posterior, long posterior construct, front and back, which is an anterior surgery done separately, posterior surgery done separately, front from back, where we rolled in the cage from behind, which you can see here through an area where we decompressed. And now what we tend to do most of the time, this is an MDR Cox, where I went in and did a posterior shortening so that the anterior void is reduced, and I need not necessarily put in a cage if I can get bone-to-bone approximation by doing a good posterior shortening. What is the evidence? There is evidence from our own country and evidence from all over the world that these patients do extremely well. And when we look at anterior versus posterior procedures, there is a lot to learn. Children have a difference. In them, TB lesion heals, but non-operative treatment, kyphosis continues to grow. In these patients, doing only an anterior surgery is dangerous because posterior elements tend to grow and kyphosis spreads. That can cause a secondary damage and a secondary insult. So in these patients, as I've learned, we use hard shield sublaminar rings. A lot of them we did only posterior surgeries which broke without addressing the anterior void. We use short segment, and in this patient, we put this large rib graft or fibula graft. In this case, it was a rib graft. We've also used mesh cages in children. We've used fibula graft in smaller children and put them with back and front. So we tend to do global surgeries, whether it's screw rod with a modified PSO or long constructs, but we do a back and front. Need not be a front anterior surgery, but a surgery from the front, from the rear. So we've combined all sorts of implants, hard shield sublaminar, rods, screws, everything put together. The spine at risk signs are actually need to be read by each one of you. These are present in children. Rajsekharan's article tells us there's an exponential increase in kyphosis in children and that these patients need to be looked at differently. He's got 4 spine at risk signs. Each one of you needs to know. A is separation of facet joints, B is a posterior retropulsion, C is a lateral translation, and D is a toppling sign. These tell us that these are global instabilities and need to be addressed not just from the front or not just from the rear, but as a composite front and back jaw. You can even predict the kyphosis by a very complex formula, but if you use it, it works in 90% accuracy. Y is equal to A plus BX, where we calculate Y as the final deformity, X is the initial loss of the vertebral body, and A and B are 2 constants, which is by Rajsekharan group as 5.5 and 30.5. So what's the evidence coming towards the end? Anterior radical debridement and reconstruction using titanium mesh cages is an acceptable surgical option for treatment in thoracic and thoracolumbar spine. Solid bony fusion does occur. However, you need separate anterior incision and anterior morbidities associated. Patients with severe symptoms who present late can also have a good outcome in TB spine, and they should be operated even at a later stage. Tuberculosis can have good results even if the neurology is addressed late. But finally, what is most important, though anterior approach is a favored method for debridement and decompression, as the lesion is anterior, there's increased morbidity related to transpleural approach. The posterior and posterolateral approach gives reasonable access to the lateral and anterior aspects of the cord for equally good decompression. Better functional outcome and significantly better sagittal plane and kyphosis correction by the posterior approach are strong pointers for a posterior approach. So to sum it up all, what are the indications for surgery without neurology? Progressive bone destruction despite anti-Cox, failure to respond to conservative therapy, increase in abscesses despite medication, uncertainty of diagnosis despite repeated biopsies, mechanical instability, a destruction of more than 2 vertebral bodies giving kyphosis, prevention of severe kyphosis in young children with extensive dorsal lesions, and large paraspinal abscesses causing collateral damage. This is where surgery is indicated even without neurology. But those with neurology, if there's a new or worsening in neurology, late onset paraplegia also is an indication for surgery. Neural arch disease, Painful paraplegia in the elderly is an indication for surgery. Spinal tumor syndrome, which is an epidural tuberculoma without much of osseous involvement, but causing neurological deficit, is an indication for surgery. Does surgery actually reduce the tissue load? Does it actually eradicate the disease? The answer is no. Then why are we operating on patients with extreme drug resistance and total drug resistance in tuberculosis without a deficit, whose fates seem to be sealed? Well, we are doing it because we believe that we are doing good. We believe that there is a duty that we need to fulfill. Do not let the fruit be the purpose of your actions so that you won't be attached to not doing your duty. Please understand, this is a very unfortunate, lonely situation for patients. And if they are willing, we should, in tuberculosis of the spine, offer them something better than this. Finally, something that I've been thinking for more than 30 years, can we eradicate tuberculosis before it eradicates us? Please think over it. I do not get sleep at times when I think of TB this way, and maybe someday you will feel the way I feel, but you will still believe that having faith is better than having fear, because we live in the hope of a better tomorrow. Thank you all for a very patient hearing. I'll be happy to take questions from anybody and everybody. Thank you so much.
Thank you, Professor Ram Chadda, for such a beautiful presentation. I think it will be very useful for the postgraduates. Now, can I request Dr. M.M. Roy to... Dr. Roy, are you there? Okay, Dr. Harshad, your comments, please. Sir, unmute yourself. Unmute yourself. We can't hear you. Sir, unmute.
Okay. Okay now?
Yes, sir.
Yeah. Dr. Chadda, excellent as usual. I have heard many a time. Very clear, very crisp. Nobody can dispute the facts of what you have told. Is there any difference between examination of the regular spine, which has got a disc or a deformity due to listhesis, etc., and a tuberculosis spine? What is it extra that you are looking at? When does the student think that, okay, this is not a disc, whereas it's a tuberculosis spine? Some clues regarding that, a postgraduate should be very happy.
Yeah. Let's just compare a disc with a TB spine. Let's keep it very simple.
Yes.
In disc, you will have unilateral symptoms and signs, while in TB spines, you'll probably have symmetrical bilateral symptoms and signs. In disc, when you check movements, one arc of movement will give you relief or no pain. Another arc of movement may be very painful and give you a tension sign. In active tuberculosis, all arcs of movement will be painful. In a disc, whatever deformity that you see, like a sciatic list, may be a temporary deformity as a spasm in response to pain. In tuberculosis, there may be spasm, but there may be a genuine bony deformity, which may be causing a deformity like a kyphoscoliosis. All these extremely important. The other important thing, the incidence of cauda equina in a disc is lower. The incidence of getting a cord compression with a cauda equina in a thoracolumbar lesion of the TB is much higher. Hence, your suspicion for doing per-rectal examinations, for doing perianal sensations, for doing bulbocavernosus reflexes, for checking clonus, for checking your hyperreflexia are extremely high. The other thing with disc will have specific dermatomal and myotomal clinical findings. TB spine may be patchy. It may not necessarily follow a dermomyotomal progression. Having said this, there are telltale signs in history, I've told you, and many more.
Yeah, thank you.
Dr. Ram Chadda, there is a question from the audience. Can we have some comment on literature of development of radical surgery for tuberculosis? And given in Korean study or Dr. Tuli middle path regime?
Yeah, now originally radical surgery was Hodgson and Stock, which came from New York group, which went in aggressively from the front, transthoracic, transpleural, went in, removed that everything and did a good decompression. They were also of the belief that this was probably reducing the tissue load and making anti-TB medication work better. So that was the radical surgery. The mid-path regime was what was documented and made popular by Professor S.M. Tully and somebody who's a father figure to all of us, and followed by Dr. Kumar and Dr. A.K. Jain, the whole group. Well, that is where we have to balance between surgery and non-surgical. We all need to know that tuberculosis basically is a medical disease. And multi-drug regenerative tuberculosis, MDR, is an even more dangerous medical disease. Our surgery is mainly done for two reasons. One is to stabilize an unstable spine, and two, to decompress the neural elements. Unlike most other pathologies, and here I'm sticking my neck out, like suppose I have two patients where I have dense shutdown neurologically in a trauma situation and a dense shutdown neurologically in a TB situation, the prognostication of the chances of recovery in a tuberculosis is much superior. So just remember that TB is not something that you should write off, the TB paraplegia or neurodeficit. Hence, continue a good mid-path regime till the time that you would need to surgically intervene, and you can always do a good decompressive if necessary. But the main reversal is based on medicines, proper dosage of medicines, proper continuation of medication, weight, and not those fixed medical components which are available, AKT4 and all those things. Please avoid those medicines, and daily doses, not the DOTS therapy.
Thank you. Dr. M.M. Roy, your comments, please, or any question for Dr. Ram Chadda? Dr. Roy, can you hear us? Sir, we can't hear.
Sir, there must be some problem from the microphone from your side. Please remove that and speak directly.
We can go to the next panelist till Dr. Roy is adjusting his microphone.
Dr. Nasir is having some.
Yeah, Dr. Mir, please.
Yeah, it was a similar question. It's a very good presentation. I like it, and students must be benefited. Similar question for the students' sake. Are there any clinical or radiological parameters to differentiate a pyogenic spondylitis and brucellosis from tuberculosis from Dr. Ramchada? Some points which favor tuberculosis than pyogenic and brucellosis.
Yeah. Let's understand a couple of things. Pyogenic discitis versus tuberculous discitis. Pyogenic discitis usually is limited to one vertebra and goes to the adjoining vertebral columns, to the upper and the lower end plate. Tuberculous originally was described as the same, but tuberculous needs to spread through the prevertebral or postvertebral channels to contiguous vertebral bodies. Next, pyogenic is a very aggressive, rapidly progressive, painful, associated with significant constitutional symptoms. Tuberculosis is a cold disease relatively and is a much slower progressive. Pyogenic usually occurs in an immune depressed patient. Patients who are taking dialysis on CKD, are taking immune depressed drugs. These are the people who will get pyogenic discitis. Tuberculosis usually occurs in an otherwise well-protected person, does not necessarily have other comorbidities. So this is basically as far as clinical. Radiologically, they will look similar. However, the T2 weighted image and the stir images may show much larger abscesses which will glow on in tuberculosis as compared to pyogenic. Pyogenic, the soft tissue element is less. Tuberculosis may be more. Pyogenic, the vertebral body is involved more and may have additional collapse and the disc gets totally eroded. End plate changes are much more if a CT is done, which is less in tuberculosis. But there's a huge overlap between both. The final distinction is a proper biopsy. And we cannot assume that this is TB or this is pyogenic without a biopsy. There are enough masqueraders both ways. So please don't try to necessarily go with just an X-ray image or just an MRI image, please insist on a tissue biopsy.
One more question is there. What about this biofilm and implants in the tuberculosis? In a tuberculosis spine, you are putting a metal there. There's no infection. We are putting, because what is the role of biofilm in tuberculosis?
Sir, there is enough literature now saying that it's much safer, and the role of biofilm does not effectively cause any problem in TB spine, even if you are putting mesh cages after having removed TB at that very time. While in pyogenic, I will still be skeptical in using a metallic cage there and think it twice and use my implant in the normal vertebrae. But in TB spine, it's now been proven way beyond doubt that it's a cold infection and you can put in your metal, and I've been putting it for a reasonable period of time, and there's enough literature to support it. So TB spine, don't get worried of putting metal even in an infected area which has just been cleaned up and you've created a void. There is no issues.
Yeah, Dr. Chadha, you did not answer that brucellosis part.
Yes, sir.
Nasser's first question.
The brucellosis again.
Tuberculosis, yeah. Brucellosis, Brucella antigen test. How good is it to diagnose?
Antigen test, exactly, sir. That's what I'm coming. That you'll have to do a Brucella antigen test, but again, a biopsy will prove, sir. When we do that, as you've noticed in my biopsy, I've asked for fungal and brucellosis, everything. Yes. So when I do a biopsy, but there is an antigen test which can be done. You're absolutely right, sir.
Yeah, we talk so much about brucellosis, but I've never seen a case in 33 years. What about you?
Similarly, I have not seen also. And regarding,
I know the story about it. Yeah. Okay, fine.
Regarding pyogenic osteomyelitis, pyogenic discitis, it is in adult. Is it not necessary? Usually, it is not found, and mostly whatever we find in adult, that is after urogenital surgery. Usually, renal surgery, bladder surgery. And after that, usually it happens in adults. And pyogenic discitis, usually it is a better of the children. Mostly it is found in the pediatric patient. Is it, Dr. Chadha?
Sir, I probably have a slightly different take because I am working in hospitals where there's a lot of dialysis which happens.
Mm-hmm.
There are a lot of patients who have been on dialysis who unfortunately get this bacteremia, and they tend to get immune depressed, as they all are. And a lot of them have come to us with various organisms which are
that I want to mean. Whatever we find in adult, that is mostly after some renal problem or urogenital problem.
We noticed a significantly high number because
that's right.
It's very, very high, and they are very, very difficult to treat, sir. They are very difficult to treat.
Dr. Ram Chadha, there's a common question in exam that what is the earliest symptom and earliest sign in tuberculosis spine?
Earliest symptom and earliest sign. So it all starts with the pain in the back, which the patient may or may not notice. That is first.
Mm-hmm.
As and when the pain in the back slowly increases, there are constitutional symptoms which come in, which again the patient may or may not notice. Loss of weight, loss of appetite. It's only after that they may develop localized tenderness at one point, and they may develop early neurology, and sphincters come last. So this is the way it goes. It starts with pain in the back, constitutional symptoms, followed by constitutional symptoms. Early gait abnormality may come in, and sphincters get involved last. That is the sequence of events.
Dr. Ram Chadha, we will have a rapid fire question session because there are so many questions placed for you. What is the reason for paraplegia and extension and paraplegia and flexion?
So that's exactly what I'm coming to. That was something which was spoken of in the earlier days, and a lot of it is related to the myelitis effect. In those patients where there's a myelus involvement, they were the people who used to go into a flaccid type of a paraplegia in extension, while those where there was an extradural compression, they were the ones who used to come with paraplegia, which was spastic in nature. And as we look at it today, we see a lot of them spastic in nature because they are picked up early and treatment is offered. So this is where we come. Most of the patients that these young boys will see in their which are presented for them are patients who have come with cord compression, thoracic myelopathy, or thoracolumbar cord conus level lesions. These are the people who will be having extradural compressions. So they will be all in flexion or spastic, incomplete.
Okay. Professor Chadha, in late onset paraplegia due to internal gibbous, Should we give ATT or only pure surgical decompression is enough?
Both need to be done, sir. I have treated with an internal gibectomy, and I've always, after doing the internal gibectomy, I've removed and sent that material for histopathology. 9 out of 10 times, you will find that there is a lesion which is active there, even though it may look dry on the imaging. That internal gibectomy, after you've done it, it may be inherently stable. You may not stabilize it, but you will find that there is some lesion there which is soft tissue in nature, which precipitated and caused that late onset paraplegia. You may stabilize it from behind or from the front, and I supplement it based on that lesion. I have operated people whom I've treated earlier for typical tuberculosis, and when I went and treated them for secondary paraplegia, late onset, they turned out to be multi-drug resistant tuberculosis. So that is something which is the additional avenue that you have to look at today. Send that for a biopsy again. You will be surprised at what you get.
Professor Chadda, Dr. Rahul from Kochi has a question that what is the sign you look on MRI for considering a cure?
So there is no real cure. I always say tuberculosis is quiescent. I do not use the word cure. I always believe that tuberculosis is something that each one of us is living with. Just like after some time, each one of us will be living with the SARS-CoV-2 virus. So today where we are, it's a quiescent form. Yes, what do we look at? Yes. Now, if you're looking at MRIs, you will look at fat marrow replacement. You will look at bony fusion. You will look at prevention of collapse. There's a lot of study now going on with PET-CT, where they're looking at FDG markers and finding out whether they can sort of call this as a healed tuberculosis. But there is no evidence as yet. So please understand it is quiescent, and a decision is a balanced decision on clinical, radiological, and hematological grounds as to when you stop anti-TB. I have seen a lot of people with sterile pus, large pockets, but bony lesions healed, and we stop the anti-TB. That sterile pus pocket remains for years on end, causing no side effects.
Professor Chadda, why tuberculosis is monoarticular in hip and multiple bone involvement in spine?
That's a good question that we should be asking the organism. But truthfully, it is because it's an end arthritis in the tuberculosis of the spine, and this tends to go to multiple levels, and that's the way it works. And there are 14% skip lesions which are described worldwide if you're doing an MRI. So this is the reason why it's like an end arthritis which goes to multiple levels, and probably it just goes and sort of stays there.
Professor Chadda, how you say that patient is cured as clinical improvement is very noted before radiological improvement?
So that's what I'm coming, sir. I don't use the word cured. You should be asking me, when do I stop the anti-TB medication? Well, we stop the anti-TB medication based on these 3 parameters which I mentioned, which is clinical symptomatology, pain has been reduced, there's a general sense of well-being, the constitutional symptoms have totally reversed, the patient is now much better on the post-operative MR and plain X-ray imaging. As I've mentioned, that you will look at the fatty marrow replacement in the vertebral bodies or fusion if you operated, and the patient is now asymptomatic. And all the other parameters, your ESR has come down, your counts have improved, your hemoglobin is better, all those things together. As I said, maybe there will come a position later where either an MRI or a PET-CT will be able to tell us on FDG recordings where to stop the AKT. Till that time, you take your call whether you're giving 12 months, 18 months, or you're one of those heroic people and stopping at 6 months. Because we have literature supporting all 3.
Professor Chadda, if MRI is taken at the end of 3 months, shows that lesion same status, but patient has improved. And now will you wait or suspect some other cause and work it up?
Thank you for the question. There's a one-line answer to that. The MRI improvement lags behind clinical recovery. So if the MRI is same, or even if it's a shade worse, but the patient is clinically better, I shall hold on.
Professor Chadda, is there any role of Mantoux test nowadays, and why it is still done?
The Mantoux test, there is no role in today's circumstances. Don't ask me why it is done. I don't do it. Sir.
Okay. What is the your protocol for follow-up, sir?
Protocol for follow-up, if I'm treating them non-surgically versus surgically. Non-surgically, if I'm treating them, I will do I will initiate treatment, and at 3 months, I will do an X-ray and an MRI both, whether it's surgical or non-surgical, and see the response. If the response is good, and if the patient continues to clinically improve, then I shall only do an MRI at the time when I'm considering stoppage of anti-TB medication, which may be 12 months in my hands. In certain situations where my chest physician says even later, we do it even later. So I have a 0 MRI and X-ray. I have a 3-month MRI and X-ray, and then I have a final MRI before stopping. In between, if there is a worsening, I will of course do another MRI. Otherwise, these are the 3 MRIs. Plain X-rays may be repeated to check the implant, to check fusion, etc. But MRIs is pre-treatment, 3 months, and stoppage of AKT.
Professor Chadda, is there any role of steroid in tuberculosis spondylitis?
I have not used steroids in tuberculosis spondylitis. However, there are surgeons who have used steroids when they use Solimedrol in the effort of building up the patient towards doing an elective surgery rather than doing an emergency surgery. Suppose somebody comes with early deficit and they are planning a surgery, there are surgeons who reduce the inflammation or the cord edema by giving injectable Solimedrol. I have not practiced it, and I cannot comment for or against it.
Dr. Tribhuvan Agarwal, your comments, please. Dr. Tribhuvan, are you with us? Okay, Dr. Himanshu. Sir, you have to unmute yourself.
Dr. Manish, I have a question.
Yeah, sure. After
Sir,
Dr. Himanshu.
Sir,
Yes.
I need to ask that while the patients are on the long-term ATT, how do you manage the side effects which are happening because of ATT? And in these patients, do you look into some nutritional factors also when doing the surgeries and during the follow-up?
So you asked me the first part of the question I understood, which is how do I look after the side effects of the anti-tuberculosis medication?
Yeah. Because they 24 months of ATT, usually they have some kind of liver issues or one or the other issues. So are they managed with the physicians, or you also have an active role in managing those issues?
I have no active role in the medical management. I'm very clear that for every patient, even typical tuberculosis, I have a chest physician or a TB specialist or an ID specialist with me in any hospital where I work. I cannot even manage vomiting and liver challenge, which most of our patients get, skin rashes, which most of our patients get. I cannot manage it, sir. I would better give it to a person.
So what is the threshold when you refer those patients to physician? Because they come to you and...
All my patients are put on AKT by my physician. I do not. I have told you theoretically these are the doses followed, and if you listen to my talk, I said this is what my physicians have taught me, and I'm sharing with you. I don't, sir. I'm not intelligent enough, not brilliant enough, sir, and I don't shy away from that.
No, it is not the case. You are quite brilliant, sir.
Because in the nook and corner, like I'm in Dehradun, in all of the hills, even you don't find a physician there. If you are an orthopedic surgeon posted there, you have to write the ATT and you have to manage them, because they will come to you with the side effects and all that thing. So that's what I was asking, because vast majority of the people also practice in the periphery. So that's the question was targeting those people.
Sir, may I go take a step forward, sir? Even if you are in Dehradun, the number of chest tuberculosis, pulmonary tuberculosis being treated by physicians would outnumber the osteoarticular tuberculosis and spinal tuberculosis that you are treating. And they would be seeing much more of the side effects than us. So it's best to take them on your side, sir.
Okay, agreed, sir. Agreed.
Dr. Vijay Raghavan.
Please involve a colleague, sir.
Dr. Ram, good evening.
Good evening, sir.
Yeah, these are COVID days. My question is, I know that practice for everybody must have come down. Have you seen any correlation or increase in the incidence of tuberculosis or any association? Because there is a lack of immune status and everything that we know. Is it too early to ask this question?
So right now I found no correlation between tuberculosis and COVID, but I may share something with you. that I have seen some sudden onset viral neurological deficits in patients, peripheral, like a toe drop and a foot drop, which are unexplained and the MRIs are clean. So I am not too sure, and that's all that I can share with you today. And of these, and I'm talking, they are in single digits, but of these, 2 out of those 5 or 6 patients turned COVID positive. That's all that I can share right now, but no correlation with TB.
Thank you.
Okay, Dr. Shankaracharya, please be ready with your presentation. So I will take 1 or 2 more questions. Sir, can you start ATT based on MRI findings if your biopsy results are negative for all?
Sir, this is now a generic question. If it's specifically being asked to me, sir, I repeat my biopsy.
You repeat your biopsy, okay.
I repeat my biopsy. The reason being, I cannot subject a patient for an empirical treatment, which in my hands is a minimum of 12 months without having adequate evidence. So I repeat a biopsy a second time. And if I don't get a biopsy, which is CT guided on a second time, I then insist on a surgical biopsy. If despite these 3, I'm in a tight corner, which you're very right, can happen very, very rarely, then after a proper counseling and putting all my cards open in front of a patient, only then rarely would I start empirical AKT. I have not had this misfortune for the last 10 to 12 years. I have been happy enough to get my biopsy reports. If not first, in second, I get a biopsy report.
Thank you, Professor Ramchadda. Dr. Shankaracharya, we'll go to the next presentation. Dr. Shankar, are you with us? Meantime, you can ask Dr.
One comment.
Please, sir.
That's all. A small
Dr.
thing.
Shankar,
Ramchadda has given an excellent lecture on spinal tuberculosis for the postgraduates, and also what he has told about the medical line of treatment. We should all know about it, but I think there's a saying in Gujarati, "Jenu kam tenu kare, visa kare, goda khaye." So you do, Dr. Himanshu, this is also for you. If an orthopedic surgeon can be there in a village or a city, definitely you will have a lot of physicians there. You can always catch somebody and ask them to treat for your tuberculosis. So medical line of treatment of all my patients, pre-operatively, post-operatively, whether tuberculosis or otherwise, even simplest of things are being treated by the medicine department. We do not treat. We treat only orthopedic point of view of a patient. But when patient is admitted under us, we are responsible as a whole. So we look at it to see that the cardiologist, the neurologist, whoever it is required to see the patient is called by our postgraduates, see the patient, and then we discuss and treat the patient finally. So I would suggest, again, just like Dr. Ramchadda has told, that medical line of treatment, particularly tuberculosis, etc., should be given by physicians and not us. Okay, but for postgraduates, they should know all the medicines and the line of treatment, at least the headlines and other things. Otherwise, failure is a chance. So how not to fail? Know all the headlines. Very much in detail doesn't matter. It is past if you don't.
Thank you, Dr. Harsha. Thank you. Dr. Shankar, please.
Good evening, everyone. I thank Indian Orthopaedic Association and Dr. Manish and everyone else of office bearers for giving me this opportunity. After this extensive talk by Ram, I think everyone must be tired, even the audience. And so I will keep it nice and simple.
Sir, audience are throwing questions. Don't worry, they are not tired. They want to learn.
Good. So my job was examination of a case of an ankylosing spondylitis. So how does it go forward? It goes from here. Okay. I think when the word ankylosing spondylitis comes to anybody's mind, this is a common picture that would come to somebody.
Sir, we can't see your screen share.
You can't see my screen?
No, we can't see your PPT, sir. You have to open it up, sir.
My screen is opened.
शंकर स्टॉप शेयर करो फिर वापस शेयर शुरू करो आप स्टॉप शेयर करो फिर अपना पावर पॉइंट खोलो और फिर स्क्रीन शेयर करो
Yes, now we can see, sir. Come from the start from the first slide, sir. We can see now.
Okay, man. This was just ankylosing. So first case. So basically, when a patient, can you hear me also and see my screen also now?
Yes, sir. We can hear you, sir.
Okay. So when we talk about ankylosing spondylitis, the first thing that comes to our mind is the patient who looks like this. He walks with a kyphotic deformity looking downwards, and a lot of times at the end stage of the disease, he's not able to look at you also, and he could be even more bent. So they have kyphosis at cervical, thoracic, lumbar, or all the areas, and they have rigid imbalance. So they sometimes may need a support, and there is a loss of horizontal gain. So this is what comes to a postgraduate's mind when somebody talks about ankylosing spondylitis. However, I will take you through the spectrum of the disease, because this is a disease when it occurs cannot be cured, and you have to manage the disease in an early stage of involvement. And so I will take you a bit through etiology, pathology, investigation, what tests to be performed, because I thought it was on basis of examination, the diagnostic criteria. And I've not focused much in this study, much in this presentation on surgical management of osteotomies, because I thought it was for postgraduate students. However, I'll briefly touch on that as well. It was described independently by three physicians and surgeons, Bechterew, Strumpel, and Mary, around at the end of the 18th century. So it was described in 1893 by Bechterew, 1897 by Strumpel, and 1898 by Mary. So they all described this, and this is a drawing from one of their presentations. Basically, the etiology is that most of the patients have a onset of sacroiliitis with pain, and most of them, when you test them, are HLA-B27 positive. Or alternatively, those normal population who have HLA-B27 positive have a high susceptibility to ankylosing spondylitis, especially if there is a triggering effect, or if there is an infection or some triggering effect. It, however, occurs very less in Africans. It has been seen more in Caucasian places. So it's a chronic inflammatory disease of unknown etiology, though there is a genetic predisposition for sure. It occurs about 6 per 10,000 population, and there is a significant male predominance. Some papers say it's about 7:1, but most of the literature quote about 3:1. There is some autosomal inheritance, so it is affected in families, but they can be a spontaneous occurrence also. So basically, you see two spectrums of the disease. You would see a patient, young man between 20 to 40 years of age, presenting to you with back pain, morning stiffness, sometimes heel pain, and difficulty in breathing, or decreased chest expansion with early tiredness. But typically, they all have back pain and morning stiffness, which gets better with activity. Or you may have a patient who comes to you with fixed deformity with very little pain, but he has musculoskeletal deformity and difficulty in walking, sitting, mobilizing, or looking forwards. That is loss of horizontal gauge, which is a big disability. Especially after the compensation of the cervical spine is finished, maximum extension is done, and they still can't look forwards, then they can't function normally. So the disease actually is an inflammatory pathology, which actually starts in the thoracolumbar junction roughly, and then goes down to the sacroiliac joint. And it is at the ligament bone interface where you get inflammation, then osteolysis, and then fibrosis, and then ankylosis. So then you ultimately come to a complete fused spine. So this is how it starts. First, there is a normal spine. Then you have early inflammation, then you start getting fusion. And then that is how the term bamboo spine has come, because even the discs get fused, and this is typically how it looks like, a bamboo spine. However, it is important to know that it affects all the organs of the body, and not only the spine. Though the sacroiliac joint is involved in 100% most of the time, and the rib junction, the costochondral junctions are involved in 70%. These are the most common. So you have decreased chest expansion and back pain, which is more common in all of the patients. However, even the eyes, uveitis is common. You get neck, so you get stiffness of the neck and complete ankylosing of the neck. And they have also osteoporosis, so you should be very careful. These people usually, when they have neck fusion, shoulder problems are also associated. And the other common is hip pathology. A lot of them would get protrusion and hip fusion and ankylosis. And a lot of times you get confused with whether the spine is the main cause of deformity or the hip. So that needs to be differentiated. and knee joints and other smaller joints are less involved, unlike in rheumatoid arthritis where they are more involved. And that is important to keep in mind. So they start slowly. It's usually in young adults, and then symptoms, as I said earlier, on the morning and after inactivity, and gradually it gets better. And at the end of the day, also this get fatigue, and sometimes they have weight loss also, because the bowels are also involved. There is an involvement of the bowels, and you can get inflammatory bowel disease with them. And hips and knees are less involved, but they could be involved. The first feature is a glass of lumbar lordosis, and then the decreased spinal movements. As Ram said, that you do the Schober's test and you do the sacroiliac joint test is also important, because the lumbar lordosis is lost first, because lumbar lordosis is normally 40 degrees, and once that is gone, you get stiffening of the spine. And then there is loss of cervical extension. Actually, we can do a lot of compensation by cervical extension. So after that is lost, you lose the horizontal gauge, and that leads to a problem. I've already spoken about this hip and knee joint involvement, and this disease progresses over a few years and finally leads to complete fusion. So you have a different spectrum of the disease. Other extra-articular involvements, as I said, is you can get uveitis in 25 to 40% of cases. You get inflammatory bowel disease, or psoriatic arthropathy is also associated with it. Osteoporosis is fairly common, and this is very important to keep in mind, especially when you have fractures on trivial trauma, or when you are doing osteotomies to correct the spinal deformities. Cardiac events may also be there, and cardiac conduction anomalies may be there, so you need to look at this. As I said earlier, chest is a big problem, and they get decreased expansion of the chest and fibrosis as well. So chest respiratory reserve is decreased, and the functional expiratory volume is significantly decreased. So that is also important. So how do you diagnose ankylosing spondylitis? They have chest pain, they have buttock pain, they may not have uveitis or enthesopathies in other heels or plantar fascia. And the onset, as I said, is early, between 20 to 40 years, insidious onset, and the persistence of pain in the back for more than 3 months, at least 3 months, and morning stiffness. So the first classification, there are so many symptomatology here. So the first organized classification was the New York classification 1984. They said if somebody has back pain for about 3 months with morning stiffness and who has sacroiliitis, then they classified sacroiliitis into grade 1 to 4. Then any of these two things are there, then that person has ankylosing spondylitis. So this is sacroiliitis. From a normal sacroiliac joint to complete ankylosis is grade 4. And it initially starts on the iliac side, and then there is sclerosis and erosions, and then from minimal to moderate sacroiliitis. So finally, the Association of Spondyloarthropathies, American Association, they said that if somebody has chronic back pain for about 3 months, onset is less than 45 years of age, and has sacroiliitis or HLA-B27 positive with any of 1 or 2 of spondyloarthropathic features like inflammatory back pain, arthritis, uveitis, dactylitis, psoriasis, irritable bowel disease, inflammatory bowel disease, and family history of spondyloarthropathy and HLA-B27, then he is considered to be having ankylosing spondylitis. So history taking and examination, you will get both the spectrum of disease. You get an end-stage disease who has a musculoskeletal deformity where mobility and horizontal gaze is for which he has come, or you will have a young man complaining to you, coming to you with back pain and morning stiffness. So when he comes down to your clinic, you must look at his gait, gaze, balance, spine, and examine the hip and other joints. And as Ram has already in great details explained to you about the neurological examination, you have to do the neurological examination. So during that time, I skipped some of this. So you have to look at the magnitude of the kyphosis, the shape of the deformity, the number of segments involved, whether it is a long segment or a short segment. And Ram also explained to you about the knuckle, the gibbous, and the round kyphosis, whether this deformity is flexible or mobile, and what is his global sagittal balance. It's all about balance in ankylosing spondylitis, and it is very important to understand that unless the spine is balanced, everything that you do for surgically would fail ultimately. So normally they get a thoracolumbar kyphosis or a cervicothoracic kyphosis. The deformity may be in either or both of places. And a lot of times we do surgical correction normally in the lumbar spine because the spinal cord ends at L1 and you can do osteotomies with less neurological risks there. And that is how we modify our surgical procedures. But sometimes, as you see in this patient, this patient, the last patient I'm showing you, he has two deformities. One, though he has a better horizontal gauge. Now, once I correct the lumbar kyphosis, then I would also have to do a modified cervical osteotomy to correct him. So we did two osteotomies in this patient. And I have shown it in many other case presentations before. So it is also important here to realize for an exam, for a postgraduate student, that the spectrum of the disease starts from the non-radiographic side, then goes to the radiographic side. So the patients may have no radiographic or no radiological features and may in early ankylosing spondylitis, when he has just back pain and sacroiliitis, which is diagnosed on an MRI. So MRI is more sensitive early on, and later on you get the radiographic changes. And it is important to keep this in mind that there is a non-radiographic ankylosing spondylitis part as well when the ankylosing spondylitis starts and then goes on to the radiographic signs and symptoms. So initial patient, when they comes, you have to do all the clinical examination. So after you have done all the clinical examination, taken the history, after you've taken the history and your clinical examination, it is important, as Ram had clearly shown, look, feel, move, exam, palpate, where is the tenderness, then you do the special test. So I've come directly to the special test. So Schober's test is described where you get the excursion of the spine for about 10 centimeters from the sacral dimple. And the modified Schober's test is going down the sacral dimple about 5 centimeters excursion. So 5 centimeters of excursion in the modified Schober's test with a chest expansion of 5 centimeters is important. So if it is less than that, you suspect has a morning stiffness and pain in the SI joint, then you suspect that he has ankylosing spondylitis. Finger to floor distance. So you must see what is the mobility of his spine, and that is also important to be measured. Then tragus to wall distance. I think that Ram also mentioned this, that patient standing erect in the wall. Normally you can touch, when you stand erect, you can normally touch your head onto the wall, but if you can't, then that distance has to be measured, and that is also important. Then you have the Faber's test, which I think most of the postgraduates will be able to demonstrate. You put the patient supine, you flex the knee and the hip, and then you abduct and external rotate. And if you get pain, then that's a positive test. There's a power flexion, abduction, and external rotation. Then you have the Ganselin's test also, which is a similar extension of the SI joint. And just to show you how this test is performed, you ask the patient to come to the edge of the bed, then you flex the other knee and bring the knee to the SI joint to be examined down, and then you stretch it further. And if the patient has pain, then that's a fairly sensitive test to tell you that the patient has got sacroiliitis. And then you have the sacroiliac joint distraction test, and you have the compression test. So both the tests can help you. So all these 4 tests will definitely tell you if the patient has got any sacroiliac joint dysfunction. At the same time, you must feel for the greater trochanter, the piriformis, the hips, and you must see if the hips are free or not, and all the movements of the hips, knee, and ankle is present or not. And that is important to keep in mind. So during a patient, so a postgraduate student can get a patient at any spectrum of this disease, from early ankylosing spondylitis to fusion, starting of fusion to complete fusion with deformity and loss of horizontal gauge. And here it is also important to know that these patients, as I said earlier, are osteoporotic, and then cervical fractures can be easily missed because you don't see the full cervical spine, and the shoulder, they have short neck. A lot of them, the shoulders are high riding, and easily in an osteoporotic spine, when you are not seeing the whole neck, you may miss. And that's something I wanted to highlight because a lot of you will be seeing these cases. And this patient had a significant cervical trauma with a minor cervical trauma with complete fracture at the cervicothoracic junction, as you can see, with opening up, epidural hematoma, and progressive neurological deficit, which was initially missed and not recognized. And that is important to keep in mind. So I have seen a lot of patients which are discovered later after a trivial trauma, 2 weeks, 3 weeks, because it is like a piece of chalk. They break and they can stay, and then they become highly unstable. So when the patient comes with a deformity, there's loss of lumbar lordosis, back motion is limited. They may have hip flexion contractures also, which is important to eliminate. So you must make sure that you examine the hip fully. The differential diagnosis that comes in with ankylosing spondylitis is rheumatoid arthritis, and they are mainly peripheral and appendicular skeleton. So it is easy to differentiate, but sometimes it may be difficult, and this is very important to take in history and examination, and then look at other joints. The commonly missed one is DISC, which is called diffuse interstitial skeletal hypodostosis. Here, however, the disc is never fused and the facet joints are never fused. It is like a candlestick. It's osteophytes which are slightly away from the vertebral body margin end. So they come a little away from the vertebral corners, and the preservation of disc is there. It's called a flowing candle wax, and there's no SI joint involved. It usually occurs after 50 to 60 years of age, and there is some genetic predisposition which makes your spine stiff, but they don't manifest as ankylosing spondylitis, and they're not inflammatory disease. The prognosis, once you have done a clinical examination and diagnosis, then you have to think of the management or give the advice. So its prognosis is worse in smokers or low socioeconomic status, good in patients who understand the disease, do their exercises and physiotherapy, because in the early disease that plays a major role, and worse in patients who are less compliant with these, worse in males, of course, and that is important to keep in mind. What are the lab investigations you would do? ESR, CRP is raised in them. There is anemia in most of them. Urinary 17 ketosteroid levels may be increased. HLA-B27 is positive in most cases. And you may do a synovial fluid examination, but for Angspond, normally that's not required. And inflammatory bowel disease, as I said, is also associated with this, and that also adds to a problem of treating them. And reactive arthritis or Riter syndrome, which are most of the interchangeable, that also occurs. Sometimes they have a reactive arthritis to a bacterial infection, chlamydia, or things like that. And then they get arthritis in large joints, and that is also associated. And radiological findings is classical flattening of the spine. So the concavity of the upper lumbar vertebral body or thoracic body is lost. It becomes square vertebra. And that is why it's called squaring of the vertebra. The first affection, however, if there's an anterior superior corner, you get osteophytes forming and then fusion occurring. And gradually it ascends up and goes up to the thoracic spine. And you can have a whole spine which is fused like a single piece. In such cases, you will find a lesion like this, which is called an Anderson lesion, because at some place there has to be a mobility. Then there is a pseudoarthrosis or hypertrophy, and sometimes you may see large gaps. These are Anderson lesions. And that is also an important thing to keep in mind for postgraduates. Radiology, you may guess, as I just said, Anderson lesion, you may get a fracture through these Anderson lesions after a trauma, and they may be very unstable. And CT, of course, is more sensitive. MRI is useful to detect disease, and DEXA scan is a must because you will know the degree of osteoporosis in them. And when I said about Anderson lesions, you may get with kyphosis or without kyphosis, and it may be through the disc or it may be through bony as well. I have seen in my experience that when I have done fixation or osteotomies, you can get an Anderson lesion below that happening newly. That is purely because a very stiff spine needs some area of mobility, and it creates a place where there is pseudoarthrosis, and that occurs, this fracture through the vertebral body. You can also early on you can see enhancements in interspinous process, and this is a classical sign of early ankylosing spondylitis, which will go on to become completely ankylosing spondylitis. If you give treatment, then it works. So this is the anterior superior corner where you get signal changes and then erosion, and then you get fusion in this. This is typical in ankylosing spondylitis early on in. So hip joints are very important because a lot of patients would have hip pathology as well. This is one large joint which gets affected in ankylosing spondylitis. You get heterotopic ossification, protrusive acetabuli, and you get fixed flexion deformities of the hip and sometimes the knee also. What is the treatment? Once you have diagnosed, you know whether the patient is early or is late. If the patient is late and the disease is more or less quiescent, he's come to you for deformity correction. then that's a different thing. But early on, you have to treat them with medications which are available to reduce symptoms and pains. So we initially start with education and pharmacological therapy. So initially non-steroidals are what is initially started, and anti-inflammatories are started. And if they respond well to that, then you can keep on with that. Disease-modifying drugs are added onto that, and once they don't respond to disease-modifying drugs, you should send them to the rheumatologist. I routinely send them to the rheumatologist as soon as I find that this is a classical case of ankylosing spondylitis and would do well with biologicals, and so I send them to our rheumatologist for human necrosis factor antibody and other new interleukin 11 or interleukin 23 which have come, Humira and others which have come. So the aim is to control pain and counteract soft tissue stiffness, reduce inflammation, and give COX-2 inhibitors, anti-inflammatory non-steroidals. And sometimes you may give cortisone for a short period of time. And beyond that, I send them to the rheumatologist, who then give them the methotrexate is routinely used, and sulfasalazine and steroids are also used, but they have their own side effects. And I understand some orthopedic surgeons in the periphery may be treating these as well. But since we are in the city and we have about 8 rheumatologists in our hospital, so it's probably best to send this to them. And this is what is available in India: human necrosis factor alpha blockers, infliximab, which is there, or etanercept, and then now you have interleukin 11 and 23, Humira, and etc., which are also used with good effects. So, but once they are used, they may have to be repeated injections have to be given, and that controls the disease and prevents the deformity as well. So rehabilitation also forms an important part of ankylosing spondylitis treatment, and that is very important for a postgraduate to keep in mind, because you must impress upon the importance of physical therapy and exercises and preventing deformities. Now, when it comes to surgical management, it's also spinal osteotomies are complex surgeries, and those must be trained. It's got a larger learning curve, and it's important to keep it in mind. So pre-operative planning of these osteotomies are very important. I have not included all these osteotomies in my presentation here because it was for an examination. So positioning of the patient, anesthesia, most of them would need fiber optic intubation. And positioning of the patient is very important, because with stiff neck and completely bent spine, you will have to actually bend the table according to the patient's position, and then later on do the correction. So there is a lot of tricks and tips and tricks in that, and you may cause major injury to vessels. And Smith-Peterson osteotomy, which was the first osteotomy, caused aortic injury as well. Cervical spine injury can also occur because by chance, because it is always flexed, so it's very important to have a Mayfield frame, or if you're putting in a horseshoe, you have to be very careful how you position the patient. So these are important things to keep in mind. As I said earlier, you have to do a proper pre-operative planning. So you have to have a whole spine X-ray in this, including the hip and the knee. And now we have the US system where we can get the whole spine X-ray done. So you have to know the sagittal vertical axis and how far it is out from the axis and where you would do an osteotomy. So there are softwares like SurgiMap where you can easily calculate the osteotomies. And this is a most common posterior wedge correction or PSO which has been done. But you can do multiple PSOs, you can do Pontis. So it depends on where is the deformity, what correction you are doing, and how much you want to do. So it can all be calculated easily before you do. And you have to do all this under neuromonitoring and very careful. So this is a patient which degrees and non-neurological deficit, and he had an inclination to one side also. And this, though he had the most of the deformity, as you can see in the cervical thoracic junction, but we chose to do a lumbar osteotomy because indirectly it is easier and you can do a correction. But however, he may need a shorter cervical osteotomy as well to get the full correction. As you can see, we have not got a full horizontalization of the gaze here, and this is his post-op picture. So we have planned to do this again. So just to take home message is that they may present early, where you must use your American spondyloarthritic criteria of back pain, sacroiliitis, HLA-B27 plus additional spondyloarthropedic symptom. Clinical examination is very, very important. Ram has gone through the neurological examination, and I have told you about the special test and then medical management. In late presentation of deformity, it is all about gait, balance, and deformity, and understanding the spinal deformity and global balance is probably very important. And then pre-operative planning and surgical management. Thank you very much. I can take questions.
Thank you, Dr. Shankar, for such a nice presentation. Dr. Rajesh Gupta, your
Sir.
comments and questions for Dr. Shankar.
Yeah, I think a very nice presentation, Dr. Shankaracharya. This is Dr. Rajesh Gupta from Jammu. I think for postgraduates, if they have seen this case, in a lifetime, they should not forget it. Such is the deformity,
Yeah.
So I think diagnosis should not be the problem. The problem is early diagnosis and the treatment, issue is if the patient is, presenting less, more than 3 months and X-rays are equivocal, should we go in for the MRI immediately?
I think so. I think if we have the symptoms which are typical and classical, then an early MRI is now available most of the places, and it is easy to do a MRI of the sacroiliac joints. Early diagnosis and early treatment can prevent deformities. It is just like tuberculosis, kyphosis. If you can prevent tuberculosis, kyphosis, and late onset kyphosis, then you prevent a big problem of trying to correct kyphosis who may develop neurological deficits. Similarly, if you can prevent ankylosing spondylitis now, the deformity of ankylosing spondylitis, you can do great justice to the patient. And also sacroiliitis, knowing sacroiliitis and eliminating tuberculosis and other things are important, because if the rheumatologist, if you want to send it to a rheumatologist and he wants to start on biologicals, then they have to rule out that there is no secondary infection, because anti-tumor necrosis factor alpha can increase infection. So I think it is mandatory, and most of the rheumatologists do it anyway. So it's important to do it.
Sir, so connection with this connection, regarding treatment, suppose we have a case of now established, the ankylosing spondylitis, and we start the patient on anti-inflammatories, right? Should we straight away go for DMRDs and tissue necroting, factor anti, those
No,
things?
I think there is a lot of variability in orthopedic surgeons as to how they start treating.
Yes.
Once they have diagnosed that the patient has sacroiliitis, and they sometimes start with DMRD like methotrexate, salazapyrin immediately. But however, I was going through the literature this morning, and the American Association says that initially you should try with with exercises and disease model with anti-inflammatory really, and then if the patient doesn't respond, then you should add the disease-modifying drugs.
Okay. So last question, I have few patients, of expand, I have put them on sulfasalazine. I have seen that drug, I don't know, I'm using for so many years now. I have seen one patient in whom, deformity got corrected. He became statin, Is it possible?
I don't know.
It is 10 years, more than 10 years treatment I am doing, and slowly and slowly he became, statins. I have not seen it. There's only one patient I have seen.
But one anecdotal cases we can't then. Yeah, I'm sure you are lucky, and the patient is lucky in that case. But salazapyrin works well, but I'm not sure about whether it can correct deformity.
Thank you very much.
Okay, Dr. Tribhuvan Agarwal, your comments, please. Dr. Tribhuvan, we can't hear you. Please unmute yourself. Dr. Tribhuvan, we can't hear you.
He's already unmuted.
Dr. Tribhuvan, we can't hear you.
Mic is not working, I think, sir.
Your mic is not working, I think. No, we can't hear you. So we go to Dr. Nasir Mir. Your comments, please. Dr. Nasir. Dr. Mir, can you hear us?
Yes. Hello.
Dr. Mir, good afternoon. Good evening. Now it's good night.
Dr. Mir, your comments or question for Dr. Shankaracharya?
What other seronegative spondylopathies one should take into consideration while diagnosing a case of ankylosing spondylitis? Should you think of other seronegative spondylopathies?
Yes, I think you will have to rule out others as well. As I said, you have to rule out rheumatoid arthritis, psoriatic arthropathy, and there's a whole spectrum of this. Whenever there is some confusion, but classically, ankylosing spondylitis is easy to spot and diagnose. And the differential diagnosis would be with dish or, as I said, Scheuermann's kyphosis is also sometimes confused with ankylosing spondylitis, something which I didn't mention here. And but in Scheuermann kyphosis, it is in a young presentation. They may become painful as well, and they are in the dorsal lumbar junction. So I think one thing which I didn't mention much was
you mentioned about anemia. Probably anemia is not common. It is only just 15%. People have anemia. Not most of them have anemia. 15%.
The anemia is essentially because by the time the patient comes to you, they may have taken anti-inflammatory and things like that and antacids, and that can cause secondary anemia.
Literature says it's 15%. 1.5.
Yeah, that's Dr. Roy.
Sometimes the ankylosing spondylitis is confused radiologically and clinically with skeletal fluorosis. Endemic skeletal fluorosis.
Yes, I agree.
Do you agree, Shankar?
Yes, I agree.
I treated many cases.
But in skeletal fluorosis, you do not get this typical bamboo spine. But when you do surgery, you may get features which are typical of ankylosing while operating the osteoporotic.
And the typical feature is the radiological irregular bone formation. Yes. In ankylosing, you get it a regular shape, but in ankylosing, skeletal fluorosis, you don't get it. There is some irregular bone formations are there. And one more information is that I had the opportunity to operate one patient of skeletal fluorosis in spine with paraplegia, though did not recover, that even under local anesthesia, because patient becomes almost skin to bone, local anesthesia, I could decompress the spine, but it did not recover, but it was possible.
Okay.
Doctor,
I have not done any sclerosis.
Because I saw one paper in China that they did it a series in decompression of the spine in skeletal fluorosis. So about 10-15 years ago, I tried, but unfortunately, it did not recover because it was in multi-level. So it did not recover. But however, information is that it is possible, even under local anesthesia, because general anesthesia is sometimes risky because of the steep spine, cervical spine, endotracheal intubation.
Actually, cervicothoracic deformity used to be done in sitting up position early on. Also on local anesthesia. So initially, when they did cervical osteotomies and correction at C5, 6, 7 junction, they used to do it under local anesthesia.
So may I ask one question to Dr. Shankaracharya? Very nice presentation, sir. I'm Himanshu from Dehradun. Sir, you said that the spine is quite osteoporotic. So is there any role of bisphosphonates in this subgroup of patients?
Yes, yes, you can treat them. You do treat them with bisphosphonates because osteoporosis has to be treated. And the bisphosphonates are osteoclast killers, so they can help. And bisphosphonates are used in ankylosing, and I use them in my practice.
And sir, how could you quantify the osteoporosis? Because the spine is already sclerotic. So is the routine DEXA scan is applicable in this subgroup?
No, there is a lot of, very good question, Dr. Koichut. There is a lot of caveat in spine DEXA because osteophytes would raise the DEXA number. So a lot of times you get false, when you get a higher number of You get a more, if the DEXA scan is -3, you may get it -2 because of the large osteophytes and fusion. So in those cases, it is important to do the hip, and even if the hip is osteoarthritic also, then you will have to do forearm as well. So, and then take a call, or you may have to do, you may have to look at generalize. You may have to involve all the joints and essentially do. But you are absolutely right that DEXA scan in ankylosing spondylitis or degenerative scoliosis or patients with a lot of osteophytes, you get a negative response with the DEXA scan. Essentially, DEXA
Yeah,
scan.
thank you. Thank you, sir.
Dr. Rajgopalan, please.
Thank you, Dr. Shankaracharya. It was a very nice talk. And ankylosing spondylitis, I think, he has emphasized all the points that the postgraduates must know. As he said, it's not a problem to diagnose in the late stages, but what is important is picking up in an early stage where it can be a little bit more confusing. Because it may not totally not start in circular joint as what we talk about. It can start with any enthesitis, even in the peripheral area. And I think all the points have been highlighted. Thank you, Dr.
Dr. Harshad. Dr. Harshad, are you with us? Okay. Dr. Harshad?
Yes. I'm here. I'm very much here. Dr. Shankaracharya. Yeah, nice presentation. I wanted to ask you one thing. If you do not treat the prognosis, how many years does it go on and where does it stop? Because I have some patients where it has stopped in between without affecting much of the hip and except only the spine and SI joint to a certain extent. Like that, there are several patients where it has stopped. You call it as burnt out case, etc. So do you have anything like that as a standardized this one, or it is individualized?
I don't think, sir, there is any standardization as such. But I agree with you. I also do see a lot of some patients where the disease is burnt out and they are managing. However,
they come for exam cases also. That's why.
Yes, they come for exam and they have very little pain or symptoms. However, they have osteoporosis and you will have to counsel them, and that is very important, and must ask them to do physiotherapy and chest exercises and all that, and so that this remains free. So they don't need DMRD then, and they don't need biologicals then. And that is also something which I have spoken to our rheumatologist, because rheumatologist, as soon as he sees a angstpond, he says he wants to be biological. But sometimes when there are burnt out disease, they don't need, and they don't have deformity which needs to be corrected, or if he's managing with a horizontal gauge, then you leave them alone under supervised neglect.
Yes.
Okay. Dr. Vijay Raghavan, are you ready with your presentation?
Yeah, one more. Once you know the clinical diagnosis, do you ask your postgraduate to examine totally, thoroughly, neurologically or not?
Yes, you always have to ask them.
You have to, yes.
It's very, very important. Right?
No, but then when both the hips are affected, can you hear me?
Yes,
yes,
sir. Yes.
Yes.
When you have to examine both the hip joints and the spine within a short time, it becomes difficult to document the spinal as well as the hip problems. So unless the examiner specifies you examine the spine only, don't worry about the hip, then it's all right. You can just make a mention of the hip, but otherwise they have to examine both. So neurologically to examine totally and completely, it becomes little difficult.
Yes. But
so where do you draw a line?
And examiners should avoid such cases in exam, putting it in exam.
No, but we do not have that many cases in many centers. So when such a patient comes, he will generally accept for this. I actually tell them to ask him to examine only the spine or only the hip joint, either one of them. The others will just mention. But otherwise, if it is not told, the student is in a dilemma. He becomes little
confused.
Scared. If I don't write here, if I don't write there, and he writes half of that and half of this.
No. He
so
should.
It is imperative that we tell them. But if we don't tell them, then
it should be clarified well before exam. That in that part you should.
Manish, can I
Yes.
say something?
Yes, sir.
Harshad, usually we don't keep. If it's a pure ankylosing spondylitis kept as a short case, we tell the students that only spine.
Short? No, sir. Long case.
Long case, usually do not give hip and the spine together.
Because nothing to demonstrate much.
Yeah.
No, that's there. Agreed. I'm not saying no. But then when you sit and write down everything, you have to write down everything and examine everything. So examining a spine and a hip within 45 minutes is impossible.
That's why
that is, if you want to write down everything.
We do not keep.
So where do you draw a line? That's what I was asking.
But
so my suggestion or clue is I have always told them, examine the spine. This is a spine case for you, or examine the hip. This is a hip case for you. Other things we can examine on cursory basis.
The line is drawn by you. Before giving the case, you see the patient. And
we should do it, but it doesn't happen in many centers. I've seen that they give it and then we come and see, and well, this is what has happened.
Dr. Manish,
anyway, they comment for examiners more than PGs.
Yes, Dr. Vijay.
I have a little problem. Share screen I went. I have the presentation on my laptop and it comes as application window. Shall I go there? Or
Ravi, just sort it out.
Yeah, 1 minute.
Do you have the PPT on your desktop?
Yeah, I have it on my desktop.
Okay, please open it, sir.
Yeah, 1 minute. Yeah, I opened it.
Now move to the icon of Zoom.
Tell me again.
Sir, is the Zoom opened on your desktop? Zoom?
1 minute. Yeah, it is open. It's open.
Zoom is open? Yeah, it's coming now.
Yeah, it is there. But I have to get my PowerPoint onto that. Now it is there on my screen.
Yeah, it's coming, sir.
We can see that, sir. You just
okay.
We can share it.
Put it on the play mode.
Yeah.
Okay, okay. You can see it? Okay.
Put it on the slide mode, sir.
I'll put it on the slide mode. Yeah. 1 minute. 1 minute. From beginning. Yeah. Okay.
Yes, sir.
Yeah. Is that okay?
No, we can't see your PPT.
Sir, move
now, yeah, it is coming. It is coming. It's okay, sir.
Sir, you can go ahead, sir.
Okay. But there is a lot of disturbance.
Sir,
there is a lot of disturbance in the.
Actually, sir, you have logged in with 2 devices. In your this thing, there are 2 devices.
Yeah.
So you have to off the other device.
Yeah, I'll take off the. Yeah, I'll take it off. Yeah, right. I'll take off the other one. Yeah, fine. Is it okay?
Yes, sir. Sir, please carry on.
Yeah. Yeah, he's just putting the other device off. That was the mobile device. Sorry.
Sir, please put off the mobile device. Otherwise, your sound will echo.
Yeah. Yeah, that is off now. Is that okay?
Yeah, you can go ahead, sir, please.
Go ahead,
can you hear? Can you hear me?
Yes, we can hear you. We can see you well, sir. You can go ahead, sir, now.
Okay, I will. Yeah. At the outset, let me thank the organizers, in particularly the IOA PG committee, headed by Dr. Rajagopal, the president, Dr. R.C. Meena, the secretary, Dr. Atul Srivastava, the treasurer, Dr. Manish Dhawan, and all the people who are working behind this excellent approach. These are COVID days, and we all know that we need to sort of approach the whole educational system in a totally online way. Are you all able to hear me?
Yes, sir.
Yeah, we can hear you.
Yeah. So thanks for the opportunity, and the topic that I have been asked to speak on is about the intervertebral disc prolapse, and most of the talk would cover the lumbar disc, but I also tried to cover, for the postgraduate sake, a little bit about the cervical disc as well, which are the common areas where you get the disc prolapse. It is essential that when we start, we should know something about the anatomy, that we all know that the intervertebral disc has got 2 major portions. One is the central liquid or the gelatinous portion called the nucleus pulposus, constituted by type 1 collagen and a lot of water content and proteoglycans, and the peripheral zone, which is the annulus fibrosus, which is more of type 2 collagen and more fibrous in nature. We also know that when you sort of plot the normalized height with the normalized concentration of various constituents like oxygen, glucose, and lactic acid, most of the time in the disc we find that it is above the critical level. Yeah. We also have to understand that the functional spine unit is not what we actually imagine, that is between the top vertebra and the vertebra below. Actually, the functional spine unit is basically constituted the intervertebral disc in between the end plate of the superior vertebra, that is the superior end plate, the inferior end plate, and also the pedicles and the fascicle joints right up to the spinous process. The weight bearing or the forces that act on the spine, about 70% of the forces act on the front of the spine and about 30% on the back of the spine. It is necessary also for us to know while examining that in the cervical spine, most of the nerve roots traverse horizontally. As you can see in the picture here, that it is traversing horizontally, and as it comes down into the lumbar region, it becomes more and more vertical. And you have got the cervical cord here, the thoracic cord, and then the lumbar spine, where it becomes the conus medullaris, then the cauda equina, and then goes down with the various roots there. When you see the clinical manifestations of prolapsed intervertebral disc, you find that the symptoms may come which are related to the disc itself, which comes in the form of back pain or discogenic pain, and symptoms related to nerve root compression, which are due to radiculopathy or root pain. And sometimes when it is in the cervical cord, we get symptoms of myelopathy or compression of the spinal cord. It is essential for us also to know, to differentiate, and this question was asked in the earlier talk with Dr. Ram Chadda as well, that a discogenic pain is most of the time a mechanical back pain, which sort of gets relieved on rest and also which gets relieved with certain positions of the spine. Whereas the inflammatory or infective pathology usually leads to pain which is continuous and which does not get relieved with any change in posture. Now, there are different zones of the disc and symptoms also can vary because of that. As you see that you can have a central disc prolapse, but most commonly we find the paramedian or the foraminal type. Rarely you get the central and the extra foraminal type, which are all shown here in the picture. Again, if you see here, this brings out that as the spine sort of traverses between L4 and L5, you have got the lumbar 4 spinal nerve root that moves and comes below the pedicle. In the cervical spine, most of the nerve roots go above the level of the pedicle. This is an important difference that we need to know. And also it is necessary to know that the disc prolapse can be in various stages. Many times an MRI is able to identify the stages of the disc prolapse, like a stage of degeneration, then moving on to a stage of disc bulge or a disc prolapse, then to a stage of extrusion, and a stage of sequestration when the whole disc material comes out and causes quite a lot of neuritis. The disc as an entity usually compresses the nerve roots when it comes out. There are small instances of the disc regenerating and also healing by itself, but I'll deal with that at a later stage. Most of the time, the cervical disc leads to the symptomatology of cervicalgia or intermittent neck pain with medial scapular pain, shoulder pain due to dorsal rami irritation. In the lower limb, you can get what is known as low back pain with sciatica, which is a common presentation for probably for the postgraduates. Every third patient that they say in the outpatient will be coming with such type of complaints, and it is essential for them to evaluate these patients. Brachialgia is another presentation which usually comes up in cervical spine. the disc, when it compresses the spinal cord, as it happens in the cervical spine, you can get, these are rare presentations, but you can get quadriparesis, you can get paraparesis, you can give anterior cord syndrome, you can get the conus medullaris syndrome and the cauda equina syndrome. As a result of the cauda equina syndrome, sometimes you can have bladder disturbance and diminished perianal sensation. So now it is also essential to localize the nerve root as per the region from where it gets affected. Like in the spinal nerves between C2 to C7, they exit above the pedicles of the respective vertebrae, as you can see in the figure here, above the level of the pedicle. But as it comes down in the lumbar spine, in the L4, L5 region, this is the L5 nerve root which comes out from the in a vertical fashion. And all spinal nerves distal to C8 exit the foramen below the pedicle, for which they are named. So for the postgraduate, this may be nice to remember this particular formula. The clinical presentation, it more commonly affects the middle-aged group. Males are more commonly again affected than the females. Onset of pain can be acute or acute on chronic. In particularly degenerative disc, you may have a chronic disease with acute symptomatology occurring once in a while. Sharp stabbing shooting pain is the usual characteristic pain, and it usually radiates along the dermatomal pattern of the concerned nerve root. And if you classically ask the patient to show you on his body where exactly the pain goes, you sometimes can make the diagnosis even as an outpatient. Trauma usually is the cause, even while lifting weights or some sort of an activity. A flexion type of injury is the one which results in a disc prolapse. This results in acute stiffness and spasm if it is an acute presentation. May not have too much of spasm if it is a chronic presentation. Radiculopathy and pain radiating to the thigh, leg or foot, one has to notice, and where exactly the patient points to this radiculopathy will probably tell you the dermatome to which it has been affecting. There can be neurological deficits, but many times neurological deficits are not the common most presentation, and it probably happens after a while. But you have to keep in mind a thorough motor, sensory and reflex examination usually will get you a diagnosis for most of the disc prolapse. There is loss of lumbar lordosis, and there can be listing, as we saw, and this listing has to be differentiated from a scoliotic deformity. The types of low back pain usually that happens in a disc disease and a degenerative disc is a typical history of back pain, which is relieved by rest, but a sudden acute pain on lifting weight with a distribution along the radicular dermatome, as is shown in the figure here. Like this is for the S1 dermatome. You can see that the pain will be classically distributed in that sense. And pain on forward bending, this is important. And we had a presentation on spinal stenosis earlier. This is the main method by which you can distinguish a canal stenosis from a disc prolapse. Usually in canal stenosis, there is relief of pain when you bend forward. When you examine the spine, you have to again go in a methodical fashion, like covering the inspection, palpation, movement and measurement, and neurological assessment. Of course, these are standard things that one has to take into account. Introduce yourself that you are a resident in a particular department, then ask permission to perform the examination, explain what the examination entails. It's preferable to expose the patient appropriately, should undress to their undergarments, including the lower limbs. And so privacy has to be provided to every patient when you examine this, which we sometimes find it difficult to do in a busy outpatient situation. Tell the patient to let you know if anything you do is uncomfortable, and then always keep looking at his face whether he has some pain. Once he is suitably undressed, usually down to the undergarments, start with the patient standing, then lying prone, and finally lying supine. Do a general observation whether the patient looks well, whether he can stand at all, or you have to provide him some help like that. And remember to inspect from all sides, as I told you, from the front, from the lateral, and from behind. And you have to look for the lumbar lordosis, the cervical lordosis, and the thoracic kyphosis as you look at this particular stage. This is about the spinal list that you can sometimes be presented with. The patient has a sideways list or tilt, and when he tries to bend forward, if he can do that, then this list might sometimes disappear. And that is the way you can distinguish from a structural deformity that occurs in scoliosis. And depending on where exactly the disc is protruded, you may find that the list occurs onto the same side or to the opposite side. So this is an important sign that you can look at. Then between the scoliotic curve and sciatic list, you can remember these points of difference. The curve direction, usually in a scoliotic curve, in idiopathic scoliosis is right-sided thoracic, but it's not a rule. But in a sciatic list, it usually depends on the side and the site of the pathology. Shoulder balance invariably is maintained in a disc bulge, but whereas in a scoliosis, you would have an imbalance. Associated pain usually not present in a scoliotic curve, but radicular pain will be the main feature in a sciatic list. Usually in scoliosis, it is a late stage presentation to have neurodeficit, but in sciatic list, you will definitely have a general presence of neurodeficit of a minor nature. You look for scars, previous surgical scars, sinuses, pigmentation in the form of cafular spots as is seen here, or in the form of patchy hair in the back. You also can start, although this is an inspectory finding, you can look for paraspinal vertebral spasm, which some examiners are very fond of asking. It can be found on inspection, but you also can palpate to find out the abnormal paravertebral spasm. Asymmetry in the shoulder height and law increase is another thing which you have to look for. And if there is any obvious limb length discrepancy, that also can be looked at. You can palpate for any vertebral slip if you find one to be observant even on inspection. Yeah. Curvatures of the spine, usually these do not present in a disc prolapse, but it is essential sometimes to find out healed tuberculosis or something else present in a patient. You may find exaggerated or reduced kyphosis, exaggerated or reduced lumbar lordosis, scoliosis and all. A round back or a hunched shoulders can be a presentation in Scheuermann's disease as a differential diagnosis, but usually not so much common for a disc prolapse. Look for gibbous, any chest deformity and scoliosis. If patient consistently stands with one leg bent, this is an important point to notice as you observe the patient, and he does not have any unequal leg lengths, then it is most probably due to nerve root tension, particularly if you are suspecting a disc prolapse, and give a lot of importance. And once he straightens the knee, he will find that he sort of resents such an examination. The lateral deviation of the spine, known as list or tilt, may be sign of a prolapse intervertebral disc causing nerve root compression. There can be associated anomalies which one should look for, particularly if you get a long case. The wall test, of which we all give some importance, is that it will unmask even small fixed flexion deformities of the hips and ask the patients to stand with the back straight against a wall. Observe whether the following are contact with the wall: the occiput, the shoulders, buttocks and the heels, and if they do not get into contact, then you must look for some deformity elsewhere. After inspecting all these aspects, you start palpating, and when you palpate, Dr. Ramchanda already told you how to identify the levels. Like the most prominent vertebra is C7, then as you go down at the spine of the scapula, you have D3, and as you come down at the angle of the scapula, lower down, it is D7. And the venous mount of venous sign, at that time it is L4, or the top of the iliac crest is L4. So with the patient standing and then perhaps later lying supine, palpate the back for. This is important that when you palpate, you must look for warmth and tenderness. And tenderness is a sign where you have to observe whether the patient actually resists the examination and shows it on the face. And it is not a sign that the patient just says he has got pain. Rotational stress from the side, as you rotate the vertebra from the side of the spinous process, can transmit the forces onto the anterior part of the vertebra also, and that is how it causes intense pain as well. In cases of the lumbosacral junctional spondylolisthesis, you can feel the step sign. the deformity of the spine, whether it is in a knuckle type or whether it is in a smooth fashion, is also something which you should look for. Next, you move on to the movements and measurements. In the cervical spine, this figure actually shows out all the type of movements that you are supposed to be examining in the neck. And many times you are able to not measure it exactly in degrees, but you have to tell it from the distance from the shoulder or the distance from the manubrium sterni and things like that. And in the lower lumbar spine, you ask them to do forward flexion and note the fingertip to floor distance. This is one method, or you can do the Schober test, which has been already alluded to in the previous talks. Extension is usually recorded as a percentage of normal. Lateral bending by marking the fingers up to the knee level or how much below the knee level it is able to go. Lateral rotation of the lumbar spine is something which is difficult to measure many times. You have to make the patient sit down on the bed and then ask him to rotate, as is seen here, and how much the shoulder rotates from the initial supine position to the rotated position is what you calculate. So that is brought down in the figure. And this is the lumbar flexion. Many times you would find just by hip flexion, the patient may sort of give a feeling that the lumbar spine is moving well, but it is essential that we sort of mask this particular effect and do the Schober's test to measure the lumbar flexion. This is lateral lumbar flexion being measured. This is how the Schober's test is done. This has been nicely brought out in the previous talks as well. Because the hip flexion can mask the absence of lumbar spine flexion, one has to do this test carefully. First, identify the dimple of Venus, as is shown here in the figure. And then you also point about 10 centimeters above and 5 centimeters below. And the whole distance is about 15 centimeters on the tape. And when you ask him to bend, he is supposed to bend at least 6 centimeters. That means the total movement should be almost about 21 centimeters after he starts bending forward. And when this happens, you know that the movement is nearly normal. A modified way to demonstrate lumbar spine flexion is to place several fingers over the lower lumbar spinous processes, but this is little subjective still, and ask the patient to bend forward and touch their toes as best as possible. In a normal spine, your fingers should move apart. If they don't move, then that is something which you should think that the spine is pretty stiff. Next, we come to the neurological assessment. This is very important, and this has to be little focused and done carefully. And sometimes subtle neurological signs have to be noticed as well. Neurological assessment is an essential part of the examination of the spine. Examination should involve a full assessment of the muscle wasting, fasciculation, which is a sign of lower motor neuron paralysis, tone, power, coordination, proprioception, sensation, and reflexes. And depending on the nerve root that is involved, I will show you a table which will tell you how to identify the nerve root involvement. There are special tests I have included here under the neurological because the femoral nerve and the boosting effect of the sciatic nerve also comes under neurology. You should do the femoral nerve stretch test, the Lassigge test, and the boosting test. Gait is something which we invariably forget to do as a routine, but this will help you also to find out if the patient is quite stiff in the back. Of course, you should do the examination of the hip joints and the sacroiliac joints. For motor and sensory, it may be worthwhile to have a table like this so that you don't forget anything. The bulk and nutrition of the muscle, upper limb, lower limb, and as per the dermatoma, the root involved in the upper limb, you know that C5 is deltoid, C6 is biceps, C7 is triceps, and as you come into the wrist area, you have the C7, C8 and T1. In the lower limb, similarly, the flexors of the hip and the flexors of hip will go in for L1, L2, and as they come down to the knee extensors, you have L3, L4, and for the tibialis anterior is L4, and EHL is L5, and you have the hamstrings with S1 and L5. So once you know this formula, you will be able to assess the muscle power in the various regions and note it down. And this is one. So the other thing is to know about the dermatomal pattern, and this you should know by heart. that L1 is around the inguinal region here, L2 is in the upper thigh, L3 is the middle thigh, L5 from the lateral aspect of the leg on to almost the great toe, almost onto the great toe in the dorsal aspect. And in the plantar aspect, you have more of S1. And we always tell this formula that my pant crease lies along S1, S2, I sit on my S2, and my fissure pinches me at S5. So if you remember this formula, you will probably able to know the dermatomal pattern as the patient describes his symptoms as well. It is essential to do the reflexes in the appropriate way, as is shown in the figure here. It is better to make the patient to sit down, relax, and then do the knee jerk, and you will be able to get the response. And the ankle jerk, preferable to dorsiflex the ankle and then do the jerk, and then you will get a positive reflex there as well. It is also important while doing reflexes that if you don't have an absent reflex, it may be worthwhile to check the upper limb reflexes also. Sometimes the patient may be hyperreflexes or hyporeflexes as a whole, and you can interpret it accordingly. In this prolapse, it is essential for postgraduate students to always evaluate the straight leg raising test. And a lot of interpretation can happen in this particular test. With the patient laid on their back, raise one leg with the knee absolutely straight. There will be no flexion deformity there or flexion at the knee until pain is experienced in the thigh, buttock, and calf. Invariably, that pain has to be as per the dermatomal involvement of the concerned root. However, sometimes the patients are not able to clearly describe this, so you have to be careful about what they are telling. Record the angle at which the pain occurs. Your normal value should be around 80-90 degrees, higher in people with ligamentous laxity. But perform the sciatic stretch test, dorsiflex the foot at the point of discomfort, and test it positive if additional pain results. Now, this is an important slide that I want you to concentrate. The first 0 to 35 degrees of straight leg raising test does not mean anything. It is probably there is slack in the sciatic arborization taken by during this range, and there is no dural movement at all during that particular phase. Most of the tension on the nerve root applies as you raise the leg between 35 to 70 degrees, as is pointed out here. And the sciatic root tends over intervertebral disc during this range, and rate of deformation diminishes as angle increases. So this is an area that you should be carefully assessing. And when you sort of reduce it by 5-10 degrees and then do dorsiflexion, you will find that the root again gets tested up. Practically no further deformation again happens as you lift the leg beyond 70 degrees. So I want postgraduates to understand that SLR, when you do, actually the value for that is as you raise the leg between 35 to 70 degrees. And in the older textbooks, you will definitely find never suspect the acute disc prolapse if you have SLR beyond 45 to 50 degrees. When the limit of SLR is reached, dorsiflexion, this already I explained, and you can continue to do that particular thing. It is important also to do the bowstring sign in order to take off the effect on the hamstring stretch and see whether the nerve root is actually involved. And as is shown here, after doing the straight leg raise, you just flex the knee and try to palpate the popliteal region for any tenderness or sciatic nerve root involvement. Now, this is very important for all postgraduates to understand. Crossed SLR sometimes is more specific for this prolapse. And that means severe root irritation is indicated when straight raise of the leg on the unaffected side produces pain on the affected side. And you have to be careful and you have to explain the test to the patient before doing it. And then SLR is sensitive, but it is unspecific. And whereas crossed SLR is very specific, but not very sensitive. And this is a very important paper that describes the value of SLR. Straight leg raising has a sensitivity of almost 91% towards this prolapse diagnosis, but its specificity is only 32%. On the other hand, crossed SLR is specific almost to the tune of 98%, but is not very sensitive. So it is important for all of us to understand how we interpret these type of tests. We then move on to the femoral nerve stretch, which we must have the patient lying prone. If we cannot lie prone, I think it's very difficult to do this in the lateral position, but we can try. Passively flex the knee as far as it goes. In a positive test, the patient should feel the pain in the ipsilateral anterior thigh. That is the distribution of the femoral nerve. Also, pain may be exacerbated on hip extension, as is shown here. He's actively extending the hip, and that can intensely cause the pain over the femoral nerve. We should perform some of these tests which have already been explained both in the previous talks. I will not delve too much of time into this. This is the pump handle test and this is the flexion, abduction, external rotation test of the hip. Both are specific for the sacroiliac joint, and this is the Ganslin's test. Now, this is a slide from Netter's diagrams. I got it that if the root involvement is L4, you will find that there is lower back pain, hip pain, posterolateral thigh and anterior leg, as is shown here. And you will find numbness along the anteromedial thigh and the knee. Quadriceps is generally slightly weak, and quadriceps wasting may be there in a very late onset or late presentation, and knee reflex will be diminished. Whereas when it is L5 root, where the L4, L5 disc has protruded or collapsed and causing pressure on the L5 root, then you would find that over the sacroiliac joint, hip and lateral thigh and leg is the pain, and numbness usually is along the lateral leg and on the great toe. Dorsiflexion of the great toe and foot may be weak, and there can be sometimes a foot drop as well, and atrophy may not be seen, and changes are quite uncommon here, and no reflex may actually be lost with an L5 root compression. In an S1 compression, which is due to a disc prolapse at L5 S1, the distribution of pain is along the sacroiliac joint, then on the back of the thigh, back of the leg, and onto the lateral aspect of the foot. The plantar flexion of the foot and great toe may be weak, and you may find some wasting of the gastrosolius, and ankle jerk invariably is diminished or absent. To differentiate between upper and motor neuron, this is very basic, but I'm just recapitulating for the postgraduates that usually in an upper motor neuron lesion, you don't see too much of muscle wasting, but in lower motor neuron, you see muscle wasting much earlier. There is increased tone there, whereas it is decreased here. There can be clonus and exaggerated deep reflexes in upper motor neuron lesion. That's a cord type of a presentation, and absent deep reflexes if it is root level lesion. Superior reflexes lost here may or may not be lost. Babinski's kind is present and is absent. And so these are some of the differences which you can always find. This is a very important literature article which tries to bring out the diagnostic value of various tests towards diagnosis of prolapsed intervertebral disc. Manual muscle testing, sensory testing, supine straight leg raise testing, Lasseguier sign, crossed Lasseguier or crossed SLR. These are the ones which are recommended for use in diagnosing lumbar disc herniation with radiculopathy. So for the if you have to do a fast examination in the OP, you can sort of do these tests in order to get to a diagnosis. And you already know the muscles which have to be tested for each of the nerve root. The common nerve roots that are involved in disc prolapse, as you know, can be L4, L5 or S1. So you can start looking for those particular muscle wasting and muscle weakness. Now come to investigations. The cornerstone of diagnosis of lumbar disc disease is the history and physical examination. But I must also tell you that there is this interesting paper which actually found out the sensitivity and specificity of various modes of diagnosis. And the clinical examination history, majority of time, only up to 65%, you are right in making the correct diagnosis. So you need to depend on investigations. Plain X-ray actually doesn't have too much of value, which I will discuss as I go along. But CT myelogram is, or contrast CT, is one very useful investigation and almost equivalent to an MRI in terms of making a diagnosis of prolapsed intervertebral disc in the lumbar region. Neurophysiological studies like nerve conduction study and EMG is also likely to help. A recent meta-analysis concluded that initial screening by the classic SLR test in conjunction with 3 or 4 symptoms in a nerve root distribution is sufficient for clinical diagnosis of lumbar disc herniation with radiculopathy. But if you are going to operate on a patient due to some indication, I think it is better to have a higher level of investigation done. Plain radiographs, majority of times, in my experience, I feel it is more to sort of rule out some other diagnosis like infection or ankylosing spondylitis or degenerative disc disorder. But it is essential sometimes to do a plain X-ray, both AP and lateral, in patients who are more than 50 years, who have significant trauma, who have some neuromuscular deficits, unexplained weight loss, suspicion of ankylosing spondylitis, history of cancer, use of corticosteroids, when they are febrile, or a recent visit for same problem and no improvement. Even if it was a disc prolapse in the first instance, if there is no improvement, before taking up for further treatment, you have to do an X-ray. CT has its advantages. They are extremely useful, highly accurate and non-invasive tool. Superior imaging of cortical and trabecular bone can be seen. And the resolution of the nerve roots sometimes can be a problem, but a contrast CT can even give you that. And contrast resolution can bring out this. Helps to differentiate between bony osteophyte from soft disc, which sometimes we cannot do it with an MRI. It has its limitations and it cannot differentiate between scar tissue and new disc herniation. It does not have sufficient soft tissue resolution to allow differentiation between annulus and nucleus. So here, as you can see, the MRI is probably the gold standard for making a intervertebral disc prolapse diagnosis, apart from the other things that you have done. And it's a test of choice. It allows direct visualization of herniated disc material and its relationship to the neural tissue. The neural tissue is definitely clearly defined in both the T1 and T2 weighted images, and so one can really see things much better. Advantages over myelography, because in the past we were doing myelography for the diagnosis of this, but it has its own inherent problems. But MRI has sorted out this issue. There is usually no radiation. It is an OP procedure. There is no intrathecal contrast and more accurate in far lateral disc. And this can sometimes be a problem with MRI. And it also has advantages over CT, and limitations are that it shows abnormal anomaly in asymptomatic patient, and sometimes you can over-treat a disc with MRI. And it is also essential to know that you have to interpret the MRI very well. As is seen here, this is just a cross-sectional picture line diagram that is shown. And the same thing as is seen in an MRI, you would see that you can trace the nerve root on either side as it is traversing down from the L4, L5 disc space. A posterolateral L4, L5 disc herniation compresses the L5 nerve root. We saw this earlier itself. Whereas an L4, L5 foraminal or extraforaminal disc extrusion, because of the vertical nature of the nerve root, extraforaminal type of a disc prolapse is likely to affect the nerve root which is above, not the L5 root, but the L4 root, as is shown in this picture very clearly. See, this is the posterolateral disc prolapse as seen in an MRI, and you can see that this is already causing so much of compression on the nerve root, you can't even see the nerve root there. And this is the now a central disc prolapse. Sometimes this can be the presentation as is seen here. You have, as you see, it is not yet sequestrated. It is still well contained, and you can see the contours of the annulus pointed out there. A far lateral disc prolapse, as is seen here, you see that it has come out somewhere here, and this sometimes can be missed by all other investigations, and only MRI will be able to tell you this. Myelography still sometimes is being done, but usually it is unnecessary if the clinical CT and MRI are conclusive of the diagnosis of disc prolapse. Indications of if you suspect an intraspinal lesions or patients when they have a spinal instrumentation and MRI is contraindicated, you can use myelography. Questionable diagnosis resulting from conflicting clinical diagnosis or a post-operative spine. These are certain situations that we may have to adopt to go for that. Now, I'll consider some of the treatment options. Majority of times, disc prolapse is to be treated non-operatively, but there are some definite indications when you have to surgically intervene. A short period of rest, not for 6 weeks continuously lying in bed and all those things are given up. Not to exceed more than 3 days. If the patient starts recovering and he starts improving in terms of the pain and the radiculopathy, that should be a clear indication that he can restrict his activity, continue the conservative treatment, and come back for reviews regularly. Oral medications in the form of NSAIDs, muscle relaxants, mild opioids when the pain is very severe, antidepressants, gabapentin, and short course of steroids may all be indicated, and not in all cases, but as per the need in a particular patient. Progressive ambulation to return to activity is what is advised, and patient reassurance. And here, for knowing the progress of the recovery, you can use the Schober's test, and this comes in very, very handy to know if the patient is really improving or not. If a patient fails to improve with 4 to 6 weeks of non-surgical care, probably you should go in for epidural injections or even a surgical management. The optimal time that one gives for non-surgical treatment in majority of cases is not more than 6 weeks, sometimes maximally up to 3 months. This is another mode of treatment which nowadays under good image control, one can give the appropriate transforaminal nerve root block, and this is one of the procedures that is being carried out, and we can know if this particular symptoms is also arising from that particular nerve.
Dr. Vijay Raghavan,
Yes.
we have to wrap up because we are running short of time.
Yeah. I think there is just about 4 or 5 slides. I'll do that. Caudal epidural block is another one most of you must know. Operative indications are absolute bladder and bowel involvement and increasing neurological deficit. If this happens or the cauda equina syndrome happens, there is no question of waiting. It almost becomes an emergency. Relative indications I have pointed out: failure of conservative treatment, recurrent sciatica, significant neurological deficit disruption, recurrent neurological deficit. And there are some contraindications which you can go through. The 2 gold standards of surgical treatment are nowadays not open laminectomy and discectomy, but to do micro discectomy or endoscopic discectomy, the transforaminal approach or the interlaminar approach. I will not show these videos because of lack of time. These 2 are actually showing the 2 types of treatment being carried out. Surgical treatment in the form of percutaneous automated discectomy, ozone therapy, laser, these all were in the literature for some time, but slowly these are all going out of vogue. Just for completion, I mentioned. These are some examples of the cases that we have treated. I don't want to spend too much time. This is one of those far lateral discs which was removed, and this is a cervical disc that was removed. So these are some current concepts for lumbar disc. I will ask every postgraduate to go and refer to this International Orthopaedics article. In fact, this summarizes the entire plan of management for a disc prolapse. The take-home message is that not all back pain is because of disc. We must look for other diagnoses also when we do not have classical evidence. Not all black disc is MRI or the cause of low back pain. Most disc prolapses can be treated conservatively. Cauda equina is a surgical emergency, and surgery is safe and cost effective in properly selected patients. And I thank you for your attention. And one must understand the basic pathoanatomy and make the appropriate correct diagnosis and localize the disease. Thank you for your attention. Thank you.
Thank you, Professor Vijay Raghavan, for such an elaborate presentation. Dr. Saurabh Kapoor, you please be ready with your presentation. By the time I will take few questions. So this is open. This presentation is open for discussion from the panelists.
I have a question.
Yes, Dr. Mir.
First, for the sake of students, I want the answer. What is the cause of pain in a disc herniation?
Most of the time, cause of pain is due to 2 or 3 reasons. One is the pressure on the nerve root due to the displaced disc. That is one. Sometimes if it is a sequestrated or extruded disc, it can cause a chemical neuritis, and that can be the cause of pain.
Dr. Harshad? Sir, we can't hear you. Dr. Harshad, we can't hear you. Please unmute yourself.
Yeah, now okay?
Yes.
Dr. Vijay Raghavan, an excellent presentation, totally in detail. Now, what I would like to also tell is many of these patients are chronic disc prolapse patients.
Yeah.
So their SLRT becomes negative.
Yeah.
So how would you like to interpret clinical point of view for the PGs?
It is an excellent question. If it is a chronic disc and if the patient is presenting after many, many months and several months repeatedly, I don't give too much importance to SLR. But if it is an acute presentation in a chronic case, I think doing an SLR and a crossed SLR will be more specific in getting you the diagnosis. You are absolutely right. In case of a very chronic disc,
yeah, if SLR is positive, it's all right. But when it is negative, then how do you ask the PGs to interpret?
No, I will not rule out the possibility of disc there. I will actually many times the lumbar disc, degenerative disc in the elderly age group may improve with conservative management. So without a definitive diagnosis, I will continue to manage him conservatively. But if he at any point in time presents the localization based on the dermatomal pattern, if that elicits itself, I would definitely be helped by an MRI, and then I will proceed.
Dr. Rajesh Gupta, please.
Yeah. So I think first few questions and then few comments. Dr. Raghavan, nice presentation, sir. This is regarding age. This is we say the middle age is common. And we used to say it is more common after 18. But what we are seeing these days, even 12, 13 years, children are coming with a disc prolapse. Any comments?
Absolutely, sir. I am with you. In fact, I read an article from a Western literature where a 9-year-old girl had a disc prolapse, and they reported that. So definitely, no age is bar. I am with you. But then for postgraduates, they must see in a 70-year-old, if they first make a diagnosis of disc prolapse, most often times they may be wrong. It may be something else. So I wanted them to get that type of a feeling. Yeah.
Yes. So any role of discography these days?
I am not doing it at all, sir. But in the past, there was definitely a role, and they were doing it.
Yes. So, sir, the question regarding Schober's test, all of us are talking of a dimple, of Venus.
Yeah.
So this corresponds to around S2, but the literature and books say you can mark any point L5 spinous process or something like that. And you can measure from that also.
You are right, sir. In practical, sometimes patients don't even cooperate to undress to that extent. So you can do it from L1 to L5 and still interpret. But the classical one is what they will ask the postgraduates to answer, sir.
Yeah. So, sir, regarding investigations, when should we go in for X-ray and when should we go in for MRI?
So in my practice, I usually, these days the patients also have to be satisfied. So from that point of view, an X-ray may be the minimal investigation with which you can start off, not for making a diagnosis of disc, but in case you are strangely in a rare instance, you can diagnose a tubercular spine or a spondylolisthesis, is well and good. From that point of view, I do an X-ray, maybe in the first or the second visit of the patient. But then when he does not improve and when he presents as a classical disc which does not sort of respond in about 3 to 4 weeks of conservative management, I straight away go for an MRI.
That is right. Now, a few comments, I think, regarding, sir, sciatic tilt, all of them may not be having neurodeficit. It is not a necessary. Some of them may not have neurodeficit. And for postgraduate, regarding radiation of the pain, most of the pain, they go to the thigh and sometimes they go to the leg, radiculopathies. And we say if it goes to the thigh, up to the knee, it usually can be from the hip or can be from the spine. But if it goes below the knee, it is from the, spine.
Yeah, I am with you, sir. All these are, I was just presenting all the classical things, but definitely you are absolutely right. I know from a OP point of view, when you are seeing so many patients, it can give you a rough idea on up to what level the pain actually radiates. You are right. If it does not radiate below knee, it is unlikely to be from the spine.
So last question, sir, regarding SLR, when we are doing SLR, is it an active SLR or is it a passive SLR? For disc prolapse.
Passive SLR is definitely what we give more importance to.
Yes, thank you. Thank you, sir. Thank you. That is all right. Yeah.
Dr. Himanshu. Sir, unmute yourself.
It was a nice, comprehensive kind of a coverage of discogenic disease. And I think he has covered almost all the classical and the newer aspects also. So I don't have much of questions as such. While examining how many in practicality, how many of these tests have a practical application? Like how many of you in your outdoors do what are the tests which are being done in the OPD on a routine basis, or which can be certain tests which are only for the theoretical purposes, which are the practical tests which are done in the OPD by most of the physicians.
Excellent question, sir. It's a practical question. In a busy OP, at best, you can't even undress the patient so much. You can definitely put your hand with the fingers on the lumbar spine and ask him to move forward and do a forward bending test. That will give you an indication of whether there is paraspinal spasm and how it moves. That is one thing which will not take more than maybe 30-40 seconds to do that. Then you should, if possible, you should try and do the SLR. However, that you have to make the patient to lie down to do the SLR. So the better thing, what I generally do is ask him to walk on the toes or walk on the heel. When he does these two tests, more or less 2 of your nerve roots weakness or muscle weakness, once there is muscle weakness, he will find that they will not be able to do this. So these are some broad steps which will help. Of course, you can do the ankle jerk by making him sit on the chair and then putting the leg onto the other leg and do the ankle jerk. And some amount of sensation testing, because many times this prolapses present with only sensory findings, will help you to think what it is. At the end of the day, I don't think you can make a definitive diagnosis purely based in the outpatient. It can only be a suspicion. And that's what we can do on a practical aspect.
Sir, is there any role of sitting SLR, which is mentioned in the McNabb's book, that is sitting SLR?
Yeah,
So,
yes, sir. That is more to identify.
Sir,
that is more for identifying a sort of a functional patient from a real patient who has got a genuine problem. Because as it has been studied anatomically, when he sits down and you're doing an SLR to 90 degrees and raise, the amount of excursion of the nerve root is very, very minimal, and he should not normally get a positivity. But many times patients react differently. Then you know that it is probably a functional case.
Okay. And Dr. Ram Chadda, last comment, and then we go to the Dr. Saurav's present. Dr. Ram Chadda.
See, I have just a couple of comments. One based on how do you quickly examine a patient in the OPD, which I think is extremely important. One, you see the patient, you make the patient lie prone, go for low back tenderness, examine your tenderness. In the prone position, you do your femoral stretch test and you do your ankle jerk. These 3 things are done in prone. Then turn the patient supine. In supine, you do a passive SLR and you do a Braggart's maneuver if you want. Bring him down. After that, you do your knee jerk. Your ankle jerk is already done. Then see your EHL, extensor hallucis on both sides. See your peronei and your FHL and plantar flexors and dorsiflexors of the ankle on either side. Having done that, you check all the sensations L2, L3, L4, L5, S1. You cannot do a per rectal or a urinary examination. Doing that, make the patient, before he sits up, look for his pulsations of dorsalis pedis and tibialis posterior bilaterally. Very, very, very important. Then make the patient stand up, flexion as mentioned by Sir, and extension. If there is an extension click, extension pain, suspect lysis or listhesis. Very, very important again. So this is as far as the quick examination. As far as sitting SLR is concerned, sir, it has become a big tool in teleconsultation today. Please understand, a sitting SLR has become a very good tool in teleconsultation today. When you make the patient sit on a chair and do the SLR, and you can actually elicit some tension signs. That's all that I have to say. Thank you very much.
Thank you, Dr.
Yeah, thank you. Thank you, sir.
Okay, Dr. Saurabh, are you ready?
Yes, I'm ready now.
Please share your screen.
Is it coming?
Yeah.
It's coming.
Screen has come, but you have to open your PPT. Yes, we can see that now.
All right. I'd like to start first by saying that a very big thanks to all these senior teachers and committee members of IOA for giving me this opportunity. It's a privilege to be among the stalwarts, and I just seek their support to make this presentation a success. So this is a long case of scoliosis, history examination, and management for postgraduates. So scoliosis in exams be like this, where you think that you are a deer and you're being hunted down by a tiger. But actually, if you have prepared well for scoliosis, you will end up knowing more than the examiner in 95% of cases. Because it's a blessing in disguise. It's reliable and reproducible findings. It has easy special tests. And if you use the right adjectives in diagnosis, you just nail the case. Now, scoliosis is a presentation. It's not a diagnosis. All these are scoliosis, but to say it's a scoliosis case is actually insufficient and you need more. What we want to know about scoliosis in clinical examination and history is, first of all, uncover the etiology, whether it's idiopathic or non-idiopathic. Where does the patient lie in its skeletal maturation chart? Is the patient pre-pubertal, post-pubertal? What are the patient complaints? Why is he coming to your clinic? Is it for cosmesis? Is it because of respiratory difficulty? Is it sitting imbalance? Or is the caregiver concerns from the parents? And when you decipher all these, you get to the management. Now, history and examination is important to remember the goals. A patient comes to you with scoliosis. Now you have to describe the scoliotic deformity through correct adjectives. You have to uncover the non-idiopathic causes of scoliosis. You have to comment on growth maturation. Where does the patient lie in the growth chart? How far he or she is away from the pre-growth velocity? Or actually has the patient crossed the stage of peak growth velocity and achieved skeletal maturity? Then demonstrate a structured pattern of history taking and examination, and finally make a complete clinical diagnosis. Now, it's useless for me to talk about history and examination unless I touch upon the pathology of scoliosis. To come on to that, for a postgraduate, just remember that scoliosis is lateral curvature of the spine more than 10 degrees. True structural scoliosis is a three-dimensional deformity. The axial rotation of the vertebra creates the rib hump. This is because when it rotates to one side, the ribs get crowded on the side of convexity and it creates a hump. And because it actually alters the entire chest wall, you have an anterior rib hump contralateral to the side of the rib hump posteriorly. A lateral shift in the coronal plane creates the surface curvature, and this also in turn also creates uneven shoulders. Now also know about what is compensated and what is uncompensated scoliosis. In compensated scoliosis, a major curve is balanced by a minor curve so that the head falls directly on the sacrum. In uncompensated scoliosis, the head falls away from the sacrum. These tend to be more severe and more symptomatic. It's also important to know that a scoliosis that starts before 10 years of age is early onset and has a different prognosis and treatment algorithm. A late onset scoliosis starts after 10 years of age. Idiopathic scoliosis occurs without any underlying trigger, whereas non-idiopathic scoliosis is secondary to a trigger like congenital, syndromic, neuromuscular, and even secondary non-structural curves. Here is a summary of non-idiopathic scoliosis etiology. Remember that in secondary non-structural curves, you have the sciatic scoliosis, you have the osteoid osteoma. The severe leg length discrepancy can also cause scoliosis. Pain-causing lesions or lower limb imbalance triggers scoliosis in these conditions. Now, the examination and the sequence of history taking remains the same. You start with history, you go on to the gait analysis, then you do inspection, palpation, measurements, neurological examination, special tests, and finally the diagnosis. And let me tell you, there are not many subheadings in these major headings, and that's why scoliosis is simple. To start with history taking, a good history taking should help you reach a narrow differential diagnosis. If your differential diagnosis is wide, probably you haven't taken a good history. The patient will always come to you with complaints of deformity or concerns regarding the shape of the back. They might put it as twisting of the back, humping of the back, uneven shoulders. Ask the patient specific questions. When was it noticed? Early onset is more progressive and is more likely to be non-idiopathic. Who noticed it? Is the parent or the patient? This is important because if the patient notices it and comes to you, that means the cosmetic problem is paramount. Ask about the progression. Is it rapidly progressive? If it is rapidly progressive, it's likely to be non-idiopathic and it will require an early intervention. Ask about body image concerns. Concern over body image is prime indication for surgery in idiopathic scoliosis. Now, pain is not common in idiopathic scoliosis, although literature tells you that almost 1/3 of cases have pain, but the pain is mild. Severe unremitting pain, think about tumor, infection, spondylolisthesis, night pain, rest pain is highly suspicious. This calls for advanced imaging. Caregiver concerns of paramount importance in neuromuscular scoliosis patients. These patients generally have low IQ. They can't tell their complaints themselves, is the parents who find it difficult to feed them, to take care of them, and that's why they come to you. These patients also suffer from functional quadriplegia. They're commonly paraplegic, and just to maintain a normal posture on a wheelchair, they have to use their both hands. That makes them quadriplegic. Ask about questions regarding cardiorespiratory compromise. Does the patient have breathing difficulty? Does he or she suffer from frequent chest infection or frequent hospitalizations? In big C-shaped curves of neuromuscular scoliosis in young patients, this is a common complaint, and it's been shown that correction of deformity reduces all these problems. Ask for weakness, sensory deficit, foot deformity, gait disturbance, and loss of balance are primary neurological symptoms with which the patient will come to you. If there is underlying neurological abnormality that has triggered scoliosis, ask for foot deformities. Pes cavus, flat foot, hammer toes are all seen with syndromic scoliosis and also underlying spinal dysraphism. Ask for associated history. Now, birth and developmental history is extremely important. Ask if there is a history of difficult and prolonged labor, delayed milestones. Is there difficulty that the child finds keeping up with the peers? Are there autistic traits? Are there learning disabilities? All these point toward syndromic scoliosis and neuromuscular scoliosis sometimes. Ask for a family history. Is there a scoliosis in the aunt maternal side or in siblings? Idiopathic scoliosis can be like that. Neurofibromatosis, Marfan's, all can run down the families. Ask for Menarche status, change of voice. Now, this gives a rough idea as to where this child lies in his or her growth chart. Post-menarchal patients normally have crossed the pre-growth velocity and have entered a phase where they're close to skeletal maturity. Of course, this has to be confirmed with proper examination. Now, starting off with the examination, we start with the gait analysis. Ask the patient to straight walk, heel walk, toe walk, check for the Romberg sign. A Romberg sign will uncover any loss of balance that might be occurring because of underlying syringomelia or a spinal cord tumor. You start from the inspection. You start from inspection from the back, head to toe. Comment on the position of the head. Comment on the hairline. Low hairline is seen in clipper field deformity. Look at the level of shoulders. Look at the prominence of scapulae. Look at the lateral margins of the trunk. Are they asymmetrical? All these have to be noted down in the correct order. Now, curvature of the spine. Describe, use the right adjectives. Record what's the location of the curvature of the spine. Is it thoracic or it's lumbar? What is the major curve, which is the largest curve? What is the side of convexity? A scoliosis is always named according to the side of convexity. Look at the contour. Is it smooth or angular? Angular scoliosis indicates underlying neural abnormality and has to be investigated with the MRI scan. What's the major curve? If it's a compensated scoliosis, there will always be a minor curve, but that again will be minor and will be less visible. Can you see a rib hump? Can you see a loin hump? Is there a step off? Spondylolisthesis sometimes itself can trigger scoliosis. In that case, those cases, many times you just need to fix the spondylolisthesis and scoliosis correct itself. Look for signs of spinal dysraphism. Is there a patch of hair or a dimple or a sinus? Coming on to inspection from the front, again, not many subheadings. You'll find prominence of the chest, which you expect contralateral to the side of the rib hump. Look at the costopelvic angles. Are there any ulcers there? Is there any area of redness? Because these become tender areas, and neuromuscular patients, because they can't complain for themselves, they cry or wince if you palpate them, which I will mention later on. Look at the position of the anterior superior iliac spines. Fixed pelvic obliquity is very commonly seen in neuromuscular scoliosis and should be recorded. Finally, inspection from the side, again, excessive lordosis, kyphosis, kyphoscoliosis, lordoscoliosis are very commonly seen in syndromic and neuromuscular patients. Look at the foot, asymmetric foot size, high arch foot, flat foot, hammer toes. They, especially in combination with sensory abnormalities and absent abdominal reflexes, indicate underlying syringomyelia or a neural tube defect. Look at the skin. Are there caffeole spots? Is there any axillary freckling? Noted down. Coming on to palpation, look for tenderness. Now, it's very uncommon to find midline tenderness in patients with idiopathic scoliosis. If you find it, think about a vertebral tumor, like osteoidostoma or osteochondroma. Tenderness can be commonly seen over a big rib hump. That's more because of a muscle imbalance, and it generally tends to be mild. Look for postopelvic tenderness. Again, in neuromuscular cases, in very narrow costopelvic angles, you might even find an ulcer. And this might be very tender, and the patient will start wincing. Although he may not speak anything, because these are patients of neuromuscular scoliosis, they can't express themselves that well. Always don't forget to measure limb length, and a limb length discrepancy itself can create a scoliosis. If you prescribe a simple shoe raise, that corrects the deformity. Now, compensated versus uncompensated scoliosis, you need a plumb line. Drop the plumb line from the inion. If not the inion, then from the C7 vertebra, which is the most prominent vertebra, and see where the plumb line drops. If it falls within the ambit of sacrum, this is a compensated scoliosis. If it falls away from it, then that's uncompensated scoliosis. Now, this is a very important test that needs to be done in order to quantify and also to achieve a few objectives. You need a scoliometer for that. It should ideally be provided. If you can buy it, take it to the exam yourself. It makes the rib hump conspicuous. Ask the patient to fold both the hands and bend forwards. An examiner looks at the patient from the side and behind. A hump becomes visible if it is in the thoracic area, and record it as a rib hump. Now, if you see a loin hump, don't call it a rib hump, please. The loin hump is because of a lumbar scoliosis, and it's present much more distally down. Record the scoliometer measurement. Ideally, when the patient is bending forwards, put your scoliometer right at the top and slightly with its hemisphere right on the furrow. Just slide it up the summit. At the summit, record the scoliometer reading. Here it is a little more than 11 degrees. Record it. This is the size of the rib hump clinically. Similarly, you can measure the size of the loin hump. Addison forward bending test will also help you differentiate between non-structural and structural scoliosis. For example, a patient with a sciatic list, if he is able to bend forwards, it should disappear. Similarly, other causes of non-structural scoliosis should disappear the curve when the patient is bending forwards. Now, flexibility is also very, very important. You have to comment on the flexibility because this will decide your further management. A very rigid curve is more likely to be non-idiopathic. If the child is small, you can just hold him up, suspend him in the air, and as you can see here, the curve will just disappear. Another way to test for flexibility is the push-prone test. You place your arm over the rib hump and do a counter by placing your other hand on the iliac crest. And if you can correct the deformity, then this is a flexible curve. Also, don't forget to look for signs of hyperflexibility. Marfanoid habitus, Marfan syndrome, Ehlers-Danlos syndrome, all are associated with scoliosis and they have different prognosis. Beighton score more than 5/9. There are 5 things need to be done and each is given a score. If the score is more than 5/9, this is definitely hyperlax individual. Look for high arched palate. Measure the arm span and measure the height. If arm span is more than the height, this indicates a Marfanoid habitus. You have to comment on that. Now coming on to the neurological examination, this has been covered very thoroughly in the previous lectures. Go through motor examination, sensory examination, reflexes. I want to make a special point about the abdominal reflexes. Frequently, it is the only finding of underlying serious neurological pathology, and absent abdominal reflex may indicate underlying syringomalia. Don't forget to test planters as well. Height measurement. Now, it's important in scoliosis because in early onset cases, the sitting height reflects the truncal growth. And if serial sitting heights do not increase while the curve increases, this indicates that there is a need for intervention. The spine is growing sideways rather than vertically, and then sooner or later, this patient will come back to you with breathing difficulty. Now, assessment of growth is another very, very important aspect of examination. All scoliosis types progress with growth spurt. And any patient that enters your clinic, you have to, through your clinical examination, find out whether this patient is still waiting for his peak growth velocity, or is he past his peak growth velocity? Has he actually achieved skeletal maturity? And that's why it's good to know about the Tanner staging. Most of the time, peak growth velocity happens between Tanner stage 2 and 3. And if you are able to detect a patient who is Tanner stage 2 and let's say has a 50-degree scoliosis, you should be able to prognosticate and tell the parents that this is very likely to progress to potentially 70 or 80-degree curve. And that's where there is the ideal window of opportunity where you can do some intervention, either bracing or preferably surgery. So again, know the Tanner staging. Know what is Tanner staging for boys. Know what is Tanner staging for females. Always ensure you have a female chaperone to help you perform Tanner staging. It is also advisable for the female chaperone alone to make all the observations, and I think that will be acceptable, especially in with the type of society and cultural values that we live in. Now, at this point of time, it's not the clinical part, but I'd like to touch upon the radiological assessment of growth. We frequently talk about razor sign. We have frequently talked about fused triradiate cartilage. Please understand that a razor sign stage 1 appears after peak growth velocity, and a razor sign stage 0 means that peak growth velocity is still away, but we can't really predict how far away it is. And a stage 5 is obviously skeletally mature. So if a patient presents you with a razor sign stage 1, is all probability this curve is not likely to progress. Also comment on the triradiate cartilage. Fused triradiate cartilage indicates skeletal maturity. They're both not good in predicting peak growth velocity. Standard staging is the most accurate, but it's complex. Again, it's a radiological thing. It's not part of the clinical examination, but the questions might be asked from you regarding this. Now, remember the red flags. Non-idiopathic scoliosis markers, early onset, rapid progression, severe unremitting pain, delayed milestones, difficult labor, weakness, gait disturbance, left-sided curves, sharp angular curves, foot deformity. If you find any of these, become alert. You're dealing with a potentially non-idiopathic cause of scoliosis. Now, keep it simple. When you make a diagnosis of scoliosis, you're summarizing all what is important for creating a logical management plan. So in your diagnosis, mention age, sex, mention what side the deformity is, mention the onset, mention the location. The curve with the greatest scoliometer reading should be mentioned first. Comment on the flexibility, whether it is compensated scoliosis or uncompensated scoliosis. Where does the patient lie with respect to the level of maturation? And finally, mention about neurological deficit and pathology. If there is no neurological deficit, mention it. I'll give you case examples. Now, this is the idiopathic scoliosis in a 6-year-old male with normal neurological examination. Now, how should you make a diagnosis? You have to include all those points, use the right adjectives, and make it structured. So you say 6-year-old male patient with a left-sided, thoracic, flexible, compensated, early onset, probable idiopathic scoliosis with no neurological deficit. So I think it's better to add probable, because sometimes you find surprises when you do advanced scans. The second example is idiopathic scoliosis in a 12-year-old girl with no neurological deficit. You say 12-year-old pre-pubertal girl with right-sided, thoracic, flexible, compensated, late onset, probable idiopathic scoliosis with no neurological deficit. This is a third example of a patient, 15-year-old girl who presents you with skin pigmentation and scoliosis. It's not difficult to understand that these are cafe or spots. So you're dealing with the case of neurofibromatosis. How will you put it? You can say 15-year-old post-menarchal girl with left-sided, thoracic, rigid, uncompensated, late onset, non-idiopathic scoliosis secondary to neurofibromatosis. Now, the management perspective for a postgraduate, I will not go into the details, but I will just talk about what should stimulate you clinically to make a management plan. Now, this is the slide. I like to revise it. So entire management revolves around the interplay of the etiology, skeletal maturation, and what does the patient come to you for. Together, you decide the management. The management can be discharge from the clinic, serial observation, bracing, or surgery. In our country, bracing may or may not be feasible, but still an option. Now, remember this one line. A curve that causes significant symptoms and or is likely to progress requires some intervention. We talk about this first case. She's a 17-year-old post-menarche girl with right-sided, thoracic, flexible, compensated, late-onset idiopathic scoliosis with no neurology. We know she's skeletally mature because she's post-menarchal. We know she's skeletally mature also because she has fused radiate cartilage, so there is no risk of significant progression. If this patient says, I have no cosmetic concerns, I'm happy with the way I look, I'll say, okay, go home, discharge, you don't need anything. But if this patient says that I don't like the way I look, then option would be, of course, to operate. So here the patient's complaints are dictating the management. Let's talk about another case. This is a 60-year-old male patient with a left-sided, thoracic, flexible, compensated, early onset probable idiopathic scoliosis and no neurological deficit. It's a 45-degree curve, and there is significant growth potential of the trunk left. This curve is likely to progress. But can you fuse it? Now, this patient is too young for fusion because he hasn't still achieved the truncal height required for normal growth of the lungs and normal breathing later on in the life. So what you can do is do a trial of bracing. If it works, controls the deformity, well and good. If not, then do a growth sparing surgery. Now, this is the case 3. This is a patient, 12-year-old patient, prepubertal, male patient, right-sided, thoracolumbar rigid, uncompensated, late onset neuromuscular scoliosis, which is secondary to cerebral palsy. These patients will have multiple issues. They will have gastroesophageal reflux. These patients will have a bad chest condition, recurrent hospitalizations, low mentation, high risk for infection. And here, the decision to operate lies with the parents. The parents feel that they find it difficulty to feed the patient is not able to do proper wheelchair sitting. It's affecting their quality of life and patient's quality of life. Of course, not known to the patient, but it does affect it. In that case, you have to operate with parental consent. Now, again, certain management perspectives for a postgraduate. We'll talk about the preoperative imaging, what minimum preoperative imaging you require. Now, indications for MRI, all patients with red flags should get an MRI scan done to rule out neurological problems like spinal bifida, spinal myelomeningocele, other types of spinal dystrophism like diastematomyelia, syringomyelia, etc. Do full spine standing radiographs, AP and lateral, so that you know what curves you're dealing with. This will also be important for your pre-op planning. Do side bending films, again, for flexibility. This is the least you have to tell to the examiner regarding the preoperative imaging. Also, you should know about Mehta angle and phase of rib. Now, examiners are very, very fond of asking what Mehta angle is, what phase of the rib is, because these have been known for a long time and they do have a bearing on the prognosis. So Mehta angle is an angle that is made between a line that is perpendicular to the end plate of the apical vertebra and a line along the rib head and the neck. The angle on the concave side minus the angle from the convex side. If it is more than 20 degrees, that's likely to progress. The original paper was done only for infantile scoliosis, but it's not uncommon for people to ask these questions even for early onset scoliosis. Again, a phase 2 rib. A phase 2 rib is a rib which is overriding the apical vertebra on the convex side. Now, this indicates progression. If it is not overriding, this is phase 1 rib, and this is likely to resolve. So remember these. Now, management perspective, again, for a postgraduate student, we're not talking hi-fi stuff, we're talking about basic stuff, and this is what the examiner will expect out of you. The definitive surgery for scoliosis is a fusion surgery. It can be either posterior or anterior. Nowadays, the trend is more towards doing posterior surgery. The goal is to achieve a well-balanced, a stable and fused spine, after maximum possible correction within safety limits. So 100% correction is never the aim. We have to do the correction, but within safety limits and achieve a fused spine, which is stable and well balanced. It is performed only after the patient has achieved a minimum T1 to T12 height of 20 centimeters, which is required for adequate lung function. In early onset scoliosis, when T1 to T12 height is less than 20 centimeters, to allow the spine to grow. You can try bracing initially. If that doesn't work, you do growth sparing options. Growing rods, magic rods, trolleys are the different options that are available. This will allow the spine to grow, but at the same time, it will control the deformity so that things don't go out of control. And once you have achieved adequate T1, T12 height, you go for definitive fusion. So the take-home message is, just remember the goals, do a structured examination, demonstrate to the examiner that you understand the pathology and that you are able to describe the pathology, know about when to do advanced imaging, know about what management options are available and what dictates the management. Thank you.
Thank you, Dr. Saurabh. Very nice presentation. Dr. Raj Gopalan.
Dr. Saurabh, it was a very nice talk, precise, to the point, and targeting the postgraduates. That is what is the aim of this program. Very well explained, without going into too much of surgical details is not required for them. Very nice. I have extremely impressed.
Thank you, sir. Thank you.
Very nice, Saurabh, to the point and very useful. Dr. Ram Chadda, please.
Ram?
It was an excellent presentation. I think he's done a brilliant sort of synopsis of the whole thing from the postgraduate's point of view. And I think it's a very, very sensible way that he's looked at it. He's also addressed a couple of favorite questions that examiners ask, like min-Mehta's angle and RVAD and such things, which is very, very good. Probably other things which the young people should know is how to calculate the various angles and the nomenclature that is asked repeatedly, like what's an end vertebra, stable vertebra. These are things which a lot of examiners tend to ask. How to measure a cob, you know, these are various questions which the youngsters would like to know. So if you can sort of just basically just mention what is neutral vertebra, what is stable vertebra, what is Mohs index, these are things which people ask. So that's how it works.
Thank you, sir. Sure.
Dr. Shankaracharya. Dr. Shankar. Dr. Shankar. Okay. Dr. Nasir Mir. Dr. Mir. I think Dr. Mir and Dr. Shankar are not. Dr. Rajesh, your comments, please.
Dr. Saurabh, very good, nice talk. I think postgraduates, before they start treating and, doing x-rays, all those things, must know how to mark the vertebra, That is very, very important. Level of the vertebra and marking of the vertebra.
Yes, I think there are anatomical landmarks for that. Scapula is D7 and spinoschapula is T3. Iliac crest is L4, but it's been covered before, so I didn't go to it. Also in scoliotic spines.
I think that is more important in scoliosis than other, other pathologies.
Dr. Shankaracharya, your comments or questions for Dr. Saurabh?
I think it's a good presentation, but as Ram said already, that I think for postgraduates, the basics of scoliosis is probably more important to differentiate whether this is a structural first or non-structural, whether the scoliosis is idiopathic or syndromic or neuromuscular or congenital, what are the differences? And as Ram has already said, what is how to measure Cobb's angle, which is the end vertebra, which is the neutral vertebra, which is the stable vertebra. How do you define as Harrington stable zones? And what are the basic broad lines of classification? And what are the importance of treatment philosophy, like maintaining sagittal balance, maintaining coronal balance, getting the end vertebrae correct in your fixation, keeping the lower end vertebra as less as possible, upper end vertebra, where are the levels, just basic things. So if an examiner or spine surgeon asks a question of scoliosis, that what is the importance of surgery? What are the plans of surgery? What do you do? What do you keep in mind? Those things he can say. But well, it's a very elaborate lecture he gave, so it's good.
Dr. Shankar, how often you get a scoliosis case in exam?
I think in the examinations, DNB examinations we've had in our center, we've always supplied some scoliosis cases. So I suppose every student would get one scoliosis. If 10 students are giving exam, one of them will get a scoliosis case. And as you know, DNB and exams are done in Ganga Hospital, our hospital, Bombay Hospital, all these places, they have scoliosis cases. So you will get scoliosis cases.
And usually you get as a long case or a short case? Long case.
Usually a long case, but they're easy cases. They are very good. So basic principles, if you know, and how you can differentiate between what is Adams bend, forward bend test, how you measure all these things, then you will pass the exam.
Yes, I think that's what I stressed on, is to do the basics right. If you do the basic physical examination things, fine. If you are able to do that very well, you can talk about the proper management, proper planning for surgery, maybe fusion levels. But these basic things, if you get it right, you've actually passed the exam already.
Manish?
Yes, sir. Yes, sir.
Regarding the exam for a DNB or MS, usually, at least I usually keep scoliosis only as a short case. Only in FNB spine, we keep it as a long case.
Dr. Nasir Mir.
I just have to make a point.
Yeah, Dr. Ram Chadha, please. Yes, Dr. Ram.
For the postgraduate, in fact, you get an ankylosing spondylitis or a scoliosis. There's a much higher chance of you're doing very well, because both the questions and the answers are very limited. It's far more dangerous to get a disc or to get a TB spine, because the examiner will always have questions that you cannot answer. In scoliosis and ankspond, there is a limit beyond which you can't go.
Absolutely, sir. And I think it's a gold medal case. If one prepares for it, you get a gold medal.
Yes.
Ram, can I have a word?
Yes, sir.
See, in earlier days, it was difficult to keep a spine case. Whenever we keep a spine case, people don't want. You know, every time we get the same problem. And slowly we introduced the spine as one long case. Then again, scoliosis, there are a lot of complaints later. Now it is accepted. But you are totally right about what you said. I'm just telling, actually speaking, a spine is much easier to pass than a hip in the exam.
Dr. Mir.
I agree with Dr. Ram that it's a very good to have a case of spine scoliosis, but still the postgraduate students have some sort of phobia about this scoliosis. But the moment they get scoliosis case, they are afraid. That thing has to go from their mind actually.
Dr. Himanshu.
Dr. Saurabh, it dates back to Rohtak when I was doing a post-graduation. I was under Dr. S.S. Sangwan, and we were the first few institutes in India which started the scoliosis surgery. And at that time, we used to do modified lead procedure like anterior release and posterior fusion, and ribs were kept in the freezer like that, preserved for the posterior fusion at a later date. So how do you monitor intraoperatively your scoliosis cases when you have a assess like somatosensory evoked potential, or you use the Stagnera wake-up test one? And this is my first question. And the talk is excellent from the PG point of view, and it's a great talk which you took, covering all the aspects of the scoliosis. And then that's my question: that how you monitor the neurologically the patient when you are correcting the spine.
Yes, so neuromonitoring is now a standard. We use both motor evoked potentials and SSEPs, but MEPs are the game changer. They are the ones that we mostly, because they are the most sensitive ones. Also, we keep a close coordination with the anesthetist, who will also tell you whether there is a sudden bradycardia or a sudden change in sympathetic activity, sudden drop in blood pressures. but mostly it is MEPs and SCCPs. Stagnara wake-up test is only done when we are in doubt. But even then, Stagnara wake-up test, even in UK, people are thinking that it's not the best thing to do, because if the patient moves, doesn't listen to you that well, or it moves her leg or his legs only partially or completely, how do you interpret that? How can you grade the strength of a toe of feet dorsiflexion when the patient is asleep? So are you dealing with a partial quad injury or not? So Stagnara wake-up test used to be gold standard, but I don't agree that it's gold standard anymore now. It's MEPs which are the gold standard.
Okay. Is there any role of putting a halos nowadays, like halopelvic frames for correcting the scoliosis?
Yes, so we used to routinely do that for rigid curves. It's also the way you assess the bending, the flexibility of the curve. Nowadays, they do stretch test under general anesthesia, where you get an idea of how rigid the curve is. And if it's actually rigid, you can do halofemoral traction, which gives you some correction intraoperatively before you have actually started. Having said that, it also increases the amount of neuromonitoring alerts. So it's a mixed bag. But yes, it has a role.
Thank you.
Dr. Harshad? Dr. Harshad?
I don't have much to comment. All comments are made very well. Saurabh Kapoor has presented excellently for a very difficult case for our postgraduates. Like everybody says, it's easier to pass if you get a spine than this one. The phobia must be removed.
Thank you.
Dr. Rajesh, your comments?
I think I already made a comment,
He's already made.
Yeah, already made a comment.
Sorry,
There's
I
no
got
more comments
disconnected.
now. Yeah.
Dr. Roy is not there. Dr. Roy. Now, actually, we had these all lectures. So it's an open discussion for any panelist to ask any speaker. And then we will wrap it up. Any questions for any panelist? Dr. Raj.
I have one question.
Yeah.
Yes.
Yes, sir. Yes, sir.
Shoot.
Hello.
Yes, sir. We can hear
Can
you.
I ask one question?
Yes, sir. Yes, sir.
Yeah, I have one question. The test for extensor hallucis longus, clinical test. I have demonstrated it can be graded as 4 or 5 depending on where you are putting the pressure on extensor of the toe. If you put it on the distal toe, you can show that there is weakness. But when you put it on proximal phalanx,
Distal toe? You mean distal phalanx?
Hello.
We can't hear him.
sorry, I got disconnected.
Yes, Dr. Harshad, now you can speak.
Yeah, I got disconnected. Okay, when you do the extensor hallucis test, when you put your pressure on the tip of the toe, the distal phalanx, most of the time you can show it as grade 4. Whereas when you press it on the, when you give resistance on the proximal phalanx dorsally, then you can really demonstrate whether it is grade 4 and 5. What is the opinion of everyone on that?
Is this, sir?
Yeah, Dr. Ramchandra,
hello.
You can clarify on that?
Ram, please.
Grade 4/5 in a painful situation has no significance. I repeat, grade 4/5 in a painful situation, no significance as far as management is concerned.
Okay.
I can live with a grade 4/5 EHL and live a normal life. It is basically the surgeon who wants to operate who will see it as 4/5, and a surgeon who wants to conserve who will see it as 5/5.
That's correct. So you need to clarify that to the postgraduates and tell them.
Yeah, even to postgraduates, Harshad, we teach them that extensor hallucis longus is not considered as a significant neurological deficit.
It didn't come.
So tibialis anterior is a different cup of tea. Manish, you can close.
Message. Yes, message.
Yes, I've got
Manish,
the
you are
letter. You can
muted.
come.
Manish is muted.
Dr. Manish,
Manish is muted.
Dr.
Yes, sir. Yes, sir.
Rajagopal,
Yeah.
good night.
Good night. Good night.
Good
Manish?
night. Yes, sir.
Is it over?
So
It
congrats,
is
Manish,
almost
again.
over. It is almost over. We have crossed more than 2,500 audience
Now
today.
also, congratulations.
But the actual count will come to know tomorrow because we have to take the count from Facebook and the YouTube also. So it was an excellent this thing, and 4 hours passed, and actually we logged in at 5 o'clock, so it is nearing 10. 5 hours. So thank you everyone. Thank you whole faculty for such a elaborate and yes, Dr. Arshad, you wanted to say anything?
Nothing. Excellent. Thumbs up to you.
And if we get questions now, we will give it to we'll put it in the groups.
Yeah.
Manish.
Yes, sir.
One thing I want to say, it has almost been a spine week. Ram had another meeting. We have a spine meeting here, and there's another local Tamil Nadu club having another spine session today or tomorrow, and many others not known to me, so many. So it's been a regular spine week, and people like Ram has to go here and there both.
No, but this is
we are coming up with the plaster week, sir.
Yeah.
Yes, and I discussed with Dr. Raj Gopalan, and
Yes.
we will be surely having. Today only I discussed with him, so we
We are ready with that.
Yes, sir. So thank you very much.
Thank all the faculty and all the panelists.
Excellent.
And thank you all. Manish, over to you.
Thank you.
Thank you, Dr. Manish. Thank you. Thank you, Dr. Raj.
Okay.
Congratulations and good luck. Stay